Yeah, live.
So welcome everyone to this webinar today, and this is the webinar on Retinoblastoma 2021 and International Symposium. And I would like to hand over to Dr. Santosh Hunawar, who's the moderator of this webinar. Santosh.
Thank you, Namrita. Namrita is the Secretary of All India Ophthalmological Society and has made efforts to organize this symposium during the Retinoblastoma week. I would like to ask Namrita to say a few words about All India Ophthalmological Society.
So thank you, Santosh, once again. And All India Ophthalmological Society is one of the largest ophthalmological society of the life members. So we are 21,000 ophthalmologists as of today. The important thing is that during this COVID era, I think we also would be number one in terms of webinars, because we've done almost about, through the AIS platform, about 150 webinars, and we have an education content of almost 500 hours plus, and a viewership which has ranged from 2,000 to almost 14,000, and average of about 4,000 per webinar. So in this Retinoblastoma Awareness Week, I'm thankful to Dr. Santosh, thankful to Oculoplasty Association of India, Dr. Usha Kim, who's the president of OPI, as well as Dr. Mukesh Sharma, who's the secretary of OPI, who've jointly organized this with the All India Ophthalmological Society. And I'm sure there would be great teaching, and welcome everybody from all parts of the world who have joined us today. Thank you.
Thank you, Namrita. Professor Mahipal Sachdev is the president of All India Ophthalmological Society and is also the chairman of Center for Sight Group of Eye Hospitals. I would request him to welcome the faculty.
Thank you very much, Dr. Santosh. Indeed, a pleasure to welcome such renowned faculty in the field of ocular tumors, and especially in retinoblastoma. I think there is a lot of work that has been done across the world for this particular disease, and things are rapidly evolving. During the COVID times, I think there is the use of the new digital technology that we have put to use, that is the All India Ophthalmological Society, to keep on doing this continuing medical education, especially with the Retinoblastoma Awareness Week that was there. It was thought pertinent to get this topic of retinoblastoma before the members of All India Ophthalmological Society. As we all know, that retinoblastoma is today something where we want that the child should be diagnosed early and the child should be able to see, and obviously we wish to reduce the mortality as much as it is. And that is something that we need to increase the awareness among ophthalmologists as to how to diagnose, what to diagnose, where to send, what are the latest treatments and what are the prognosis, etc. So I'm sure with such a galaxy of international speakers and national speakers who have significant expertise and have seen large number of cases, this particular webinar will be of great benefit to everybody. I think we would be learning a lot from all of your experience, and without much ado, I'll just wish all the success for this particular webinar to be a happy learning experience for all the members of All India Ophthalmological Society, and obviously there are overseas members who will be attending that. Thank you very much.
Thank you, sir. Dr. Usha Kim is from Arvind Eye Care System, Madurai, and she is the current president of Oculoplasty Association of India. I request Usha to say a few words.
Thank you, Santosh. I think it's been a privilege to have a very important session conducted alongside of All India Ophthalmic Society. The OPI and All India Ophthalmic Society is proud to have all the faculty on board. And I think retinoblastoma as such has gained a lot of importance because it's a childhood tumor with a good prognosis and outcomes. And with the evolution in terms of diagnosis and management, we have really come a long way. And with all the eloquent, eminent, and experienced speakers today from both from India and outside the world, I think we're very, very privileged to have this session during this awareness week. So we're happy to have all the guests on board, and I'm sure it will be a very useful program for not only the people who are practicing retinoblastoma, but also for all the rest of the ophthalmologists, not only in India, outside as well. Thank you so much for being part of this wonderful meeting, and welcome you all for this meeting.
Thank you, Usha. Mukesh Sharma is the Secretary of OPI. Mukesh, would you want to welcome the faculty? I think it's frozen. All right. Mukesh can talk later. Now, can we move on to Ritika? You have something to say?
Yes, sir.
All right.
I'll just start sharing my screen.
My fellows are helping me organize this, so they want to sing a song.
Okay. Let's start at the very beginning. A very good place to start. When you sing, you begin with do, re, mi. When you treat, you begin with A to E, A to E, A to E. So let's try to make it simple. A tumor, the smallest tumor. B, I'm closer to the disc. C, I see it so close to me. D, they're all so far away. E, I've grown to fill the eye. So you've got to catch me fast. T, cryo chemo, you should try. That will bring back happiness. Oh, 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 oh. When you know the tricks to treat, you can treat most anything.
Thank you, Ritika.
Thank you. I will just, as we all know that we also have a quiz and it's going to be quite exciting. So if you still have not registered for it, please quickly send in your name, your affiliation and email ID to the number that's displayed on the screen. It's 8500-452020. Thank you. I'll just stop sharing.
I'll start my screen sharing, and we'll actually have a panel discussion first, followed by the talks. And this panel discussion has been prepared keeping in mind the questions that most of the people who treat retinoblastoma have in their minds. So I'll go through a series of pictures and cases and ask you all to respond to it. You know, anybody can respond to it, but I'll ask a particular person to respond to it initially, and then after that, anybody can comment on it. Can you see my screen?
Yes.
All right. So let's start with this particular patient, 2.5-year-old male, bilateral retinoblastoma, right eye, group A. Left eye was primarily enucleated. So how do you treat this small tumor in the right eye? What would be your preferred approach? Ashwin, would you want to take it?
Yeah. So you're obviously treating a patient as a whole, but with specific, if this question is specifically only about the right eye, then a tiny tumor like that is amicable to focal therapy alone. And if it's far in the periphery like that, I wonder if cryoprobe can reach that. Lasers are great as well for something peripheral like that.
So what would be your preferred modality, TTT, laser photocoagulation, or cryotherapy for a tumor of this sort located intranasally?
Laser photocoagulation, 532 nanometer comes to mind when I see that picture.
This was actually treated with TTT, and you can see a small flat scar that follows. How many of you would treat this with laser photocoagulation as opposed to TTT?
Do you actually think TTT exists? It was a nice term that the Dutch introduced with the idea that you could gently heat a tumor, and if it had some chemotherapy about the same time before, during, or after, that you had a better response. My experience is if you don't photocoagulate it and get a burn, you're not successful. So we don't use the term TTT, although I think we're all talking about the same thing. And the other thing is in the decision here, we would laser, but the critical point is whether or not this tumor has seeds over it. And it's not always so easy to see. It's a lot easier to see with OCT. In this location, it's not easy to see with OCT. If you laser this and it has overlying seeds, you're going to fail. And this is the only eye that's going to see. So it's a critical decision. Cryo would get those overlying seeds, but obviously have a bigger scar and potential for more problems. But I don't think TTT exists.
I concur. OCT has plays a great role in this patient, especially when we want to try and detect small tumors. This child being bilateral can potentially have very small invisible tumors in the rest of the retina. We would strongly suggest OCT screening as well.
Minutes.
Mahesh, if you do photocoagulation in retinoblastoma, what precautions do you take? What precautions would you advise that retina specialists would want to take?
No, I would agree with you. I would also treat this with TTT. It's much easier to treat because a larger spot, and with a single spot, you should be able to treat this tumor. But if I were to do laser photocoagulation, I would probably use a lower power, longer duration burns, probably 200 to 500 milliseconds, and surround it with 2 rows of dense burns. And prefer not to treat over the surface, particularly people who are not familiar with treating retinoblastoma. I would suggest that they don't treat over the surface with the LIO, particularly because with the LIO, you may not get a larger spot size. So possibility of rupturing the ILM is there. So I would suggest treating all around with 2 rows of dense burns and allow the tumor to regress. But if you're going to treat over that, then defocus the beam a little bit, make it a little larger, use a little longer duration and lower power to make sure that we are not rupturing the internal limiting membrane. And usually the results will be seen about 4 to 6 weeks later.
Yeah, I think Mahesh makes a great point. There is a difference between laser and TTT. Laser is around the tumor where you coagulate the feeder vessels, causing the tumor to secondarily involute, whereas TTT is directly to the tumor and should be gentler, bigger spot, smaller power, longer duration to slow cook. Because if you laser directly to this tumor with a small 200 small spot, you could break the internal limiting membrane and seed the tumor.
Carol, we gave up the argon laser 20 years ago and only used the 810 nanometer laser. I'd like to hear everyone else's thoughts. You know, the problem is the beams, the spot size is so small comparatively that for so many of the things we treat, it just, it's torture to do, and it's easy with the TTT, with the indirect 810. So I'd be interested to hear what people are using. Again, we abandoned that years ago.
Yes, in our practice, we use the 810 also. We get better uptake in the RPE and in the choroid, especially if the choroid is pigmented. So yes, I agree with David. We use the 810 also.
Dr. Shields, while on it, would you do right on top of the tumor, or would you surround it with a little bit of laser as well? Would you want a very tight scar, or would you want a little larger scar? Would you be happy with a larger scar?
So if this is a unilateral case, and the child is not on chemotherapy and we were going to laser this, I would surround it. And I'd probably do broad spot, low dose TTT to the apex of the tumor and smaller spots surrounding. But if the child is on chemotherapy, I would just do my TTT directly to the tumor because you're getting a chemotherapy benefit.
Right. So as you rightly said, if you were to just laser this and not surround it with a little bit of laser, then you might tend to have a local tumor recurrence, and a larger TTT would probably prevent the edge recurrence as you see in this patient. But don't you think this is too large a scar for such a small tumor? How do you minimize this larger scar formation, and what complications would you expect, and what are your TTT parameters?
Santosh, I was going to bring you back to the original case and say, why did you take out the left eye? See, one of the things about the nice presentation about staging is that staging was designed when we were using systemic chemotherapy, where treating vitreous seeds was very difficult. We saved very few eyes, either with radiation or systemic chemotherapy, and that's why we go from A to E, and EIs just have enormous seeding characteristically. But that was 25 years ago. Seeding now, it is unusual that you can't save an eye with seeding.
I
So
totally agree.
that eye potentially, I don't know what its vision potential was, but
There
thanks
was
to intravitreal, intraarterial, you could save that left eye.
It was an eye with ciliary body invasion and neovascular glaucoma. So that was a different. Well, we'll go to those cases a little later. But how would you minimize the risk of large scar formation and retinal break in TTT? And what are your parameters, Dr. Shields?
Yeah, so basically your number one goal here is to treat the tumor and save the eye. No matter what size the scar, you want to save this eye because this is the eye that the child's going to see with. And if this child was on chemotherapy, we would have just done TTT directly to the tumor. If he's not on chemotherapy, it would have been a larger scar. Our parameters, in an eye that has heavy pigmentation like this eye, we'd probably start with 200, 250 milliwatt power, maybe 3 minutes of TTT directly to the tumor using the 810 laser and a spot size of 2 millimeters.
Great. Swati, would you want to take this? Do you think this is an acceptable endpoint for TTT? These are two tumors. Of course, the child was on intravenous chemotherapy as well. And MRI had shown pinealoblastoma, and he was treated for that as well. But for this right eye, these are the two tumors that have been treated with TTT, and this is the scar that we have. Are you happy with the scar, or do you want to go further and want to see a flat scar in all? You're muted.
You might want to factor into this the fact that this child presented at the age of 3 years, right? Not 3 months?
3 months.
3 months. Ah, okay, sorry.
Yeah,
Well, this is
Dr.
always-
Honavar, so
Sorry.
go ahead, Dr. Abramson.
No, I was going to say, this is our biggest challenge, and that is post-treatment with anything. If you have a scar where you really can't identify anything, if you have it appears completely calcified, you feel pretty good. But very often you have some greasy, fuzzy stuff that's there that sometimes grows, often doesn't grow, and you don't know if you should intervene or not. And it's especially delicate when you're dealing with tumors that are near the posterior pole. And I don't think any of us has, we all have our clinical guidelines and we're all successful, but we also all make a mistake. And when we go back on photographs, we realize 4 months ago, we should have treated someone. So, when I look at that photograph, the tumor to my left in the upper part looks fleshy, almost as if it's somewhat elevated. And that would be of concern, but you could be fooled here either way. We would probably treat that again on that visit. Of course, this kid's got a bigger problem with a pineal tumor.
Correct.
I'd like to add to that a little bit by saying that those types of scars can be followed well again by OCTs, and serial OCTs on the same scan can help us detect any changes. So a handheld OCT like Bioptigen is almost indispensable in our practice right now.
Right. So coming to that, Ashwin, this is a very small tumor in the right eye in the papillomacular area. Right, it remains stable. I didn't treat it mainly because the child's other eye was also treated and it has a scar involving the macula, and this vision is poor. The child has esotropia in the left eye. Would you want to simply observe or go ahead and treat it? Because treating this would mean that the child may have a central scotoma.
I fully agree. I think the tiny tumor, the papillomacular bundle is very challenging that way. Only if it shows signs of growth would you want to present some form of chemotherapy to that tumor. But otherwise, following that with an OCT is good. I'm assuming you've already treated this child with chemotherapy and we're
That's
following.
right. That's right. Dr. Shields, would you have any disagreement with that?
Totally agree. We would have done exactly as you did. Treat all the peripheral tumors and any tumor in the macula, not just the papillomacular bundle, in the macula, we tend to follow. So we did a study years ago where we looked at 68 consecutive macular retinoblastomas treated with systemic chemotherapy and observation. And we only found recurrence in 30%, which is not bad. That means 70% of patients got by just with systemic chemotherapy alone. So the 30% that have recurrence, you can go back and shrink it down with the chemo again and then TTT it, or you can use intraarterial chemotherapy.
Okay, nice. So we'll go to the next one. Swati, you want to take this?
Dr. Honavar, if you don't mind, can you go back to that, not the previous one, the previous,
This one?
Yeah, this one I had a comment that I think what it looks like, both the lesions are cavitary variants. Like the left picture, if we see, there are few areas which are less translucent.
Right.
So I think
That's an
That
important
came up after
observation.
chemotherapy. It was a solid area, but following chemotherapy, that's the kind of regression that was achieved. Little bit of calcification, but yes, there are
I
very
think
small
both,
areas.
even the superotemporal as well, it looks like cavities which are present just above that calcified areas. There are few which are less translucent compared to the rest of the tumor.
Well, this was solid, but this particular area was cavity.
Yeah.
Yes, so
sorry.
Dr. Swathi, what does that mean to you when you see cavitary?
Yeah, I think it's important to recognize that, because sometimes people just go on over treating them, expecting that they show the same response as other tumors where they will just shrink to very small size. So these cavitary retinoblastomas being well differentiated tumors, we do not expect the size to shrink more than 20%. Usually we see only the reduction in the size by up to 20%.
I'd agree with you with a big but, B-U-T, and that is, unfortunately, that's not true about all the cavitary tumors. So it's definitely true if you radiate them, give them any form of systemic chemotherapy, often you see absolutely no change, but you will also see classic cavitary grow and progress. So it's what we say about differentiated is true, but not every one of those cells in every one of those patients is that.
Yeah, agree.
Swati, this was for you. What are the specific indications for cryotherapy, and what do you think are the contraindications?
Is this for me, Dr. Honavar?
Yes.
Yeah, sorry. Yeah. So the specific, usually, at least in my practice, when it is a small lesion, if it is even in the periphery, even at the aura, if I'm able to indent it well and I'm able to reach it with TTT, I would prefer to do that. But if it is a larger lesion, as I can see here, this is slightly larger lesion, so it would be difficult to do a TTT. In such cases, cryotherapy would certainly be preferable. But also we have to be mindful that sometimes over treating with cryotherapy itself can just cause the child can come back with hemorrhage the next time. So I think that again, we have to be careful. So the specific indications, I would say this size tumor, I would certainly go for cryotherapy. Contraindications, I think if there is associated retinal detachment that is present, sometimes it may be associated with a bullous retinal detachment. In such cases, I would avoid doing cryotherapy. Or if there is any retinal break nearby, in such cases, again, I would avoid cryotherapy.
Would you avoid cryotherapy in a tumor which is on the temporal periphery, which is slightly around the equator or maybe anterior to the equator? Would you consider that there's a risk of epiretinal membrane formation or macular drag?
Yes, certainly. I think the location, again, it matters because as you mentioned, I think epiretinal membrane can sometimes form, especially if it is in the temporal area. Yes.
Mahesh, go ahead, sir. Go ahead, Dr. Arvind.
Could I add two thoughts about cryo? The first is that when you see a retinoblastoma that is a hemisphere, in other words, the height is about half the base, almost always those tumors have no overlying seeding. When you see them where the height is greater than the base, you may not appreciate it clinically, but they often have seeding. The second is something that Tim Murray pointed out literally in one line more than 10 years ago, and unfortunately, I think is very correct. And that is patients, I remember a paper I wrote 30 years ago on a few hundred cryos that I had done, and I had one long-standing detachment. So I think seeing long-standing detachments from cryo were really unusual. But any patient who has had systemic or intra-arterial chemotherapy to whom you do cryo has a much higher chance of developing a retinal detachment. And they develop regmatogenous retinal detachments where you cryo and eat through the overlying retina, they develop a classic regmatogenous detachment. So if I cryo, and all my patients land up having intra-arterial chemotherapy, if I cryo, I'll put a laser barrier either at the same time or before I do the cryo. But I'd be interested to see if others have had the same experience, again, with any form of intra-arterial or intravenous chemotherapy and detachment.
Mahesh?
Yeah. So can I make a comment? I'd like to go speak about that nasal tumor that you cryoed. It was a little bit large for cryotherapy. In general, we like to cryo lesions that are 3 millimeters or less, and that looked like it was about 4 millimeters in elevation. You know, one might consider giving a few rounds of chemotherapy, shrink it down, then do the cryo. So regarding David's point, years ago with Carolyn Baumel, who's currently a retina specialist, she looked at 900 consecutive eyes from Wills Eye Hospital in the pre-chemotherapy era and found that 9 patients, 1 out of 100, got a regmatogenous detachment following treatment, and it was usually a cryotherapy-induced atrophic hole. Then we later looked at our experience in the intra-arterial chemotherapy eyes, and we found, I think, 6 or 7 that had regmatogenous retinal detachment. And it was significantly related to endophytic tumor. Because when an endophytic tumor responds to IAC, sometimes you're left with a paper-thin retina. And that's where the atrophic retina can lead to a regmatogenous detachment. Because we do not consolidate anybody after IAC. And so we can't blame ourselves for any treatment-induced regmatogenous detachment after IAC. It's related to the configuration of the tumor.
Mahesh, is there a way of gentler cryotherapy, or do you still do heavy triple freeze-thaw cryotherapy?
When I choose cryo versus laser is when the posterior border of the tumor, sometimes the periphery is so elevated, the posterior border of the tumor is not seen. The posterior slope of the tumor is not seen well for the laser to uptake, then I do cryo. And if I'm doing only cryotherapy, I would probably go ahead with the triple freeze thaw. But if it is under cover of a chemotherapy, or for instance, a child is undergoing IV chemotherapy, then probably a single freeze thaw or a double freeze thaw, depending on the size of the tumor. And because the child will anyway come back for a follow-up about a month later, is what I use. So if it is only cryo and if it's just a single peripheral tumor, then I would still go ahead with the triple freeze thaw. But otherwise, I have shifted over to a gentler chemotherapy, cryotherapy now.
We'll go to the next one. Is Vikas Khetan logged in? Vikas? Are you there? Okay, so probably Seema can take it. Is Seema around?
Vikas is logged in, but he is muted.
Seema, it's a 4-month-old child, bilateral macular tumors, group B. What is your preferred management?
It's a bilateral tumor in a small child, so I would prefer to go for intravenous chemotherapy as a first-line treatment, and then depending on the response, follow it up with focal therapy, whichever is appropriate.
Okay. This child responded very beautifully to intravenous chemotherapy. That's what we gave. And this is just after first cycle, the tumor is nearly totally calcified. So do you find that younger children respond better to intravenous chemotherapy or intra-arterial chemotherapy, like children who are in 3, 4 months, 5 months, 6 months age group, than older children?
Yes, sir. So younger age, the response rate is very fast. Unlike in the older kids that we see, the response of IV chemo seems to be very fast. So, and we do see patients even after 1 cycle of chemo, sometimes the whole tumor is just calcified.
Okay, in that situation where the tumor is nearly totally regressed after, say, 1 or 2 cycles of chemotherapy or 3 cycles of chemotherapy, would you start off with TTT and not continue with 6 cycles? Is that something that you would do ever?
So again, as a practice, if we start the child on IV chemo, we prefer to give 6 cycles of chemotherapy. So rather than shifting to the focal therapy, if systemic chemo is started, I would like to finish the 6 cycles. And then even after 6 cycles, if there is still some residual, then probably would go for the focal therapy.
Shields, any comments on that? Bilateral macular tumor in a 4-month-old child. What is your preferred treatment?
We
You're
gave
asking
up.
me?
Oh,
David.
sorry, Carol.
Go ahead.
We gave up systemic chemotherapy 16 years ago. I'm never going back. If you've ever driven a Porsche compared to a little car that has one wheel, you'll never go back. We would treat this child with bilateral intraarterial chemotherapy. And the reason is that you certainly can get a very good result with systemic chemotherapy here. But do you want to spend the next half hour talking about what you've done to that child from the chemotherapy? Are you aware of it? What do you think the risk of developing a fatal leukemia is from 6 cycles of 3 drugs? We should ask the speaker. You gave it. What do you think it is?
Yeah, there is risk, but their situations are different. From United States to India, bilateral chemotherapy would, actually patients have to sell their house to get bilateral chemotherapy in India. So it's not very easy for us to give, although we have all the techniques, we have 98% cannulation success, we have the best of technicians, best of interventional neuroradiologists, but patients simply can't afford. In a situation of that sort, we have to treat them. And we do what is best available that patients can afford. So in this situation, of course, the question was whether you would continue up until 6 cycles, or would you want to cut short chemotherapy, say 3 or 4 cycles, and then treat the small residual with TTT.
I think treating the residual amount of tumor that there is quite challenging. Trying to stay far away from over lasering anywhere close to the macula is important. So again, OCT guided is one of the suggestions, but perhaps if we do see something growing back from any of these lesions that are closer to the macula, the new option that's coming up is the periocular topotecan insert, which is a silicone cup, and the STEP-RB trial will help tell us whether that's an option for patients like this.
Does as you know, I was the first in the world to do periocular carboplatin, and I was the first to give it up. There's not a question of whether it has an action. It does. It gives you doses that are about 10 times the intravenous dose. So an eye that progressed with systemic chemotherapy, given the same drug, periocular, will respond. But going beyond respond, curing, we gave it up. Don't do it. And I introduced it.
Yeah,
That
that's carboplatin, but he's talking topotecan.
And I'm talking about the topotecan insert, which is specific to the STEP-RB trial, which is something that stays on the eye for 6 weeks and diffuses through the eye. So the chemotherapy is not a pulse. It's actually quite continuous over some time. And Dr. Galli will tell you a lot about that trial because she's trying to make it a multicentric one right now.
Great. We'll move to the next one. This is an 11-day-old child.
I have a question on that, Santosh.
Yeah.
So I had 2 similar cases who responded very well, and most of them do respond very well, the macular tumors after systemic chemotherapy. But once you have a small lesion which is not responded and is sitting on this calcified mound, I mean, I don't think TTT is going to work on that since it's sitting on this rock. So really, if we do not have intraarterial, I mean, what other options do we have? Because like you said, yes, ma'am. Like you said, yeah.
You make a very good point. When you have recurrence over a calcified mound of retinoblastoma, systemic chemotherapy may shrink it, but it's not likely to get it completely away because it's so ischemic. And even intraarterial chemotherapy, you can try it, but there's a recurrence rate that you have to deal with. So in those cases, we resort to plaque radiotherapy.
Like this child, for a macular residual following chemotherapy, whether it's IAC or IVC, would you do plaque at this stage?
If it's recurrent after IVC or IAC and it's over a calcified mound, the only thing we have found that works is plaque radiotherapy.
Right, that's what we did here, and it worked beautifully. This is following plaque brachytherapy, and that was a macular tumor. And this is a similar situation where following chemotherapy, this is a macular residual, and that's following plaque brachytherapy, and the subtle lesion has remained stable for over 2 years now.
You know, akin to what Carol said earlier, in the days when we used plaques without chemotherapy, it was just magic the way it worked. In the world of any form of chemotherapy, intravenous or intraarterial, when you combine it with plaque, whether the plaque is first or second, the incidence of vascular complications is sky high. I like to tell people it's a little bit like drinking and driving. Probably the two of them are more or less safe, but you put them together, they're not. So we get forced into this situation, but it's something we really worry about because of complications. I wonder if anybody else has noticed that.
Yeah, we have similar experience, Dr. Abramson. I'll show you a couple of cases of that sort. Nandan, are you logged in? Nandan, can you take this? This is a macular tumor treated with intravenous chemotherapy. And as you can see, it is cystic. There are multiple cysts within it. So how do you deal with such tumors?
So typically in a macular tumor, if the intravenous chemotherapy has shown a good response, we would observe, will not hurry up with doing any laser in that area initially. And if it remains stable over time, we probably continue to observe. However, if there is any increase in size of tumor on follow-ups, then we could consider a secondary intraarterial chemotherapy in this case.
Dr. Shields, what is your endpoint when you treat cystic macular retinoblastoma?
Stability. So as long as the lesion is stable, I do nothing extra. If I see that there's recurrence in a case, for example, like this, I'd probably do intraarterial chemotherapy.
Patty, are all cysts in retinoblastoma the same histopathologically?
Most of it, what you see is just a cavity lined by the tumor cells. In the majority of cases, they are very well differentiated cells and they have this fluid. I see it, and I have this paper that I haven't finished, but most of them, 90-something%, are associated with exophytic tumor that has some retinal detachment. So that fluid from the retinal detachment, this is the one that is going to be there. Sometimes you have some macrophages in post-treatment in those areas. This is the least frequent, and sometimes you have blood. So, but the majority are these tumor cells lining areas with subretinal-like fluid.
So Patty, they're not true cysts, they're cavities.
They are cavities, yes. Yes.
This is something that you are alluding to, Dr. Abramson. This is a patient who underwent plaque brachytherapy following chemotherapy, and you see this abnormal response, necrosis and hemorrhage, which of course took time to settle down, and it settled down beautifully well. But sometimes you could confuse this for aggressive recurrence. So how do you deal with these situations?
You are absolutely right. You can confuse it. And at least you had a view here that was reasonable. Sometimes the view is so bad, you really don't know what to do. I'm curious to ask, why is it that we see such an exaggerated response in these patients? Again, to me, it doesn't matter whether it's intravenous or intraarterial, and it doesn't matter which came first, the radiation. Why is that? Does anybody know? Why is that? Why is that happening?
Possibly microvascular changes that predisposes them to an exaggerated radiation response, a kind of an exaggerated or accelerated radiation retinopathy.
But you know, we're not the only people in the world using combination radiation and chemotherapy for cancer.
Well, there is an oncologist on the panel, Dr. Vijayanand Reddy. When chemotherapy is given along with radiation, don't you see exaggerated response? That's called chemoradiation. Dr. Reddy? Well, you can ask him later when he comes on board.
I know the answer to that. And of course, you know, there are many protocols where you do that on purpose because specific chemotherapy is radiomimetic, and the hope that you can decrease the dose either of the radiation or of the chemotherapy. But it's a striking thing, and it definitely has caused us to use fewer and fewer plaques now than we did in the pre-chemotherapy world.
But I don't want to ask you this question. Of course, you'd say 100%. The question was, how often do you do IAC for a Group B macular tumor? But for my Indian colleagues, Mahesh, Seema, how often do you do IAC for a Group B macular tumor?
Yeah, I wish we could own a Porsche as well, like Professor Abramson said, but of course I can't afford one. Similarly, neither can my patient. So I wish if the patient is able to afford one, yes, I would prefer an IAC for these patients. But otherwise, yes, most often it is IVC because the patient cannot afford it.
Swati?
Yeah, I agree with Dr. Shanmugam. I think it's always the affordability issue. So if the patient can afford, definitely we would choose intraarterial chemotherapy. So it's mainly, I think, the parent dependent rather than the treating doctor dependent most of the times in our practice.
What about you, Rachna?
So personally, for Group A tumors, I do not advise intraarterial chemotherapy. Yes, I would go ahead for upfront enucleation, and depending on the high-risk features, we would go ahead and give adjuvant.
Group B, right, Rachna?
Group B, not E. I thought it was B for Bombay. You're talking about this tumor. Yeah. Yes, of course. So for this, yes, again, same. Affordability is an issue with Indian patients. Most of them are poor. We would go ahead with systemic chemotherapy unless they can afford IAC. Right, it's the same.
So this question for Dr. Shields. This is a 3-month-old child, bilateral retinoblastoma. We, of course, had to treat with intravenous chemotherapy for logistic reasons and TTT. Would you have treated this differently? Would you have considered bilateral IAC? And what's your age cutoff for bilateral IAC?
So we would have used systemic chemotherapy also. We would have consolidated after regression of the tumors. We would have reserved IAC for any recurrences. And we would not have likely done, we try to avoid bilateral IAC. So IAC we can do as young as about 3 months. We've done a 2-month-old with IAC. And the oldest patient we've done with IAC was a 31-year-old patient who had late onset RB.
Dr. Abramson?
Well, we routinely 95%, as you'll see in my talk, of all the bilateral patients I see receive bilateral intraarterial chemotherapy. Just like the case you mentioned, Santosh, with rubeosis, secondary glaucoma, et cetera, we don't treat those eyes. But as you might imagine, the eyes that get referred to me are not the easiest to treat. And we treat 95% of patients with bilateral intraarterial chemotherapy. That's simple. You know, you have an interesting clinical feature here that I'm sure the experts know. If you look at that tumor in the upper left and the tumor in the upper right, do you see how you can kind of vaguely see blood vessels around the tumor, and then in the center where it looks as if it's overexposed picture, you don't see blood vessels? It may well be that it's overexposed because it's a dark fundus, but you see that in the upper right, that tumor on the left, you see its height compared to its base. You see that white. And what that tells you is that overlying that are seeds. We call them impending seeds. With OCT, you'll see they're literally sitting right on the tumor. So they look like they're a tumor, but in fact, they're seeds. So when you see a bright whitish area that's not an artifact, and you don't see any blood vessels there, and you see blood vessels around it, you're dealing with seeds, which raises the question of how you're going to manage it.
What's your age cutoff?
Even if there are seeds, they would respond to both intraarterial or intravenous chemotherapy.
They would, but they'd be cured by intraarterial many-fold more times. But they would respond.
I just had a question for our Indian colleagues. Has anyone done bilateral IAC?
Yeah, we have done bilateral IAC, but in a deserving situation. But well. I mean, it was a bilateral recurrence, and parents were very keen on it. Of course, we have the technology to do it. It's not that it's not possible, but it is more expensive. That's the reason. They have to use different
As a primary treatment.
Primary treatment we have.
So when we have to treat both eyes with IAC, we do not do tandem. We do sequential. We take the eye that has the potential best vision and do it first because we want to clear it up. So we do one eye, and then Ann Leahy asks us to wait 3 weeks and then do the other eye. So we go back and forth, right versus left eye.
So when you do
systemic chemo because of side effects, Carol?
It's so that we can get the proper dose that we want to each eye. So we don't have to cut back and use like carboplatin, because we worry about carboplatin-induced ischemia. We really like melphalan and topotecan. So we will go back and forth between the eyes to allow us to have the best drugs and the best dose. And also, to reduce systemic problems too.
Like this child received 3 IACs, but if the response were to be as good as this, would you stop at 1 or 2 and then minimal residual would you take care of by TTT, or would you go ahead with 3 or 4 cycles of IAC?
Who you're asking?
Dr. Shields.
Yeah, so we generally use 3 cycles of IAC. That's usually what I tell the parents. But if it's a really big tumor, I'll tell them 4 cycles of IAC. Most patients get 3 cycles. We do not consolidate any patient. We have found no need to do any TTT, cryo, or consolidation unless there's a recurrence. And that's very different from intravenous chemotherapy. And yes, there have been instances where we've done just 1 IAC, and for some reason the child can't have further IACs, and we've seen remarkable good response with 1 or even 2. But I have to say the average number of IACs is 3.
So, we have Dr. Vijayanand Reddy with us.
Just one more question. Do you continue intravenous chemotherapy after IAC? Am I audible, Santosh?
Yeah, you're audible very much. So you asked whether intravenous chemotherapy has to be, well, I have some cases that needed it. I'll show you that. But yes, of course, if there is incomplete regression after IAC, we have to continue to treat this children.
So I have a question. So if you have a bilateral case where you're giving intraarterial chemotherapy for both eyes, would you not give systemic chemotherapy after that?
We never do it.
Not for the tumor itself, but for bilateral tumors, systemic chemotherapy we say is indicated. But so if we give IAC separately to both the eyes upfront in these cases, then we don't go ahead. I mean, do we give? I mean, what is the
we don't have to. We don't have to.
What are you treating? What are you treating? The eye, the patient? Why?
Yes. From what we have been reading up and to my knowledge, for all bilateral cases, we do give intravenous chemotherapy for reducing the risk of the third tumor. So in most instances, because otherwise also intravenous chemotherapy is something that is affordable by our patients. But I was just wondering if we had to do IAC for these patients, if they could afford it. So I just wanted to know whether you still go ahead and give intravenous chemotherapy in these cases.
No, Rachna, not until it's indicated. Not just because they're bilateral. You don't have to. In fact, they have a higher risk of having second malignant neoplasms, such as even leukemia.
We don't give it, and we publish there's not a higher incidence of trilateral retinoblastoma in the patients who only get intraarterial. So the concept of giving it systemically is hopeful, but it actually hasn't turned out to be true.
That's contrary to what Anna Meadows and Ann Leahy have published. That
it is contrary to what they published.
Yeah, giving systemic chemotherapy could reduce the risk of pinealoblastoma. But if we're giving IAC to a child who has germline mutation retinoblastoma, we will not give additional intravenous chemotherapy just for that reason.
How often after IAC would you need to give intravitreal injections? This is a patient where there is diffuse vitreous seeding following 3 sessions of IAC. And after that, how would you treat the residual vitreous seeds?
Is Francis Meunier on the call?
No, he's not here. He is stuck somewhere in the mountains. He couldn't join.
I think this is a great question because I don't think there's anyone here who has a firm answer of what you should do. And to some extent, it might even be influenced by whether or not that patient can easily come back to you. There's no question that if you start adding intravitreal chemotherapy after intraarterial, that the time that you have to treat is shorter and you get really good responses. We didn't talk about side effects, but really good responses. But you don't really know if you needed it. You don't know if you needed 1 or 2 or how many you needed. And I don't think we have the answer to that question. It does raise a question that you and I have talked about, Santosh, and that is, does intravitreal topotecan work? Guillermo?
Well, we have seen definitely very good action of intravitreal topotecan. We are still questioning about the dose. Probably we are using a lower dose that can be used, so we still have a way forward and increasing the dose for intravitreal topotecan. But yes, we had seen very good responses, even also intracamerular topotecan. We were able to achieve complete responses in some cases.
As you know, there's
Go ahead.
Go ahead, Carol.
The beauty of intravitreal topotecan is it lasts long and it has very little side effect profile. Melphalan, on the other hand, is powerful, reliable, but every once in a while you're going to get burned and the RPE is going to get mottled, or there's going to be hemorrhage in the eye from injection. So, you know, you take the powerful one versus maybe the less powerful one, and you have to make your decision which direction you're going to go with these meds.
Yeah, what we do in South America, is mostly start with intravitreous topotecan and then save intravitreous melphalan for second line. So that is trying to, as Carol has said, to avoid mostly the toxicity of intravitreal melphalan. Sorry.
Does anybody use intravitreous? Go ahead. Swati?
Sorry, Dr. Sorry. Yeah, so I was just adding that at least in my practice, I am using only intravitreal topotecan. Only if it fails, we are changing it to intravitreal melphalan, because we have seen a lot of side effects with intravitreal melphalan. And I think there's a beautiful paper as well that's published by Honawa's group, where they have shown that intravitreal topotecan works very well for vitreous seeds. And I have seen it practically too.
Well, there's no question the patients do well. And I encourage everyone to read the paper that was just published last month by Anthony Daniels. The question is it from the intravitreal topotecan or just a delayed response from the previous treatment? Because all the eyes that you've treated had some form of chemotherapy. And at, say, 2 months, you say it needs more treatment, and you inject in the vitreous, and a month later they're better, you say, well, that's because I injected. Well, they may have done just as well if you hadn't injected. So I go on record as saying, with the doses we're using, the same as everybody else, 20 to 30, we have lots of successes. We just published that. I'm personally not convinced that it cured anybody.
So we have a different...
Points out there are no side effects. And I agree completely. And, you know, we just published 2 papers on that. I personally worry about drugs that have no side effects.
Okay. This is a situation where IC has been performed elsewhere, and it's reported that there was no response at all. And in fact, the tumor started very subtly increasing in size following intraarterial chemotherapy. Have you encountered this situation where the IAC was technically performed very well, drugs were given properly, the dosage chosen was correct, but yet there was no response and it was increasing. Tumor was increasing.
Two questions. How many drugs were used?
This patient, I believe, received 3 drugs.
3 drugs. So there's no way this was done properly.
Yeah,
There's no
I would
way.
agree. We would doubt that they even got the ophthalmic artery. You know, something was done wrong here, or the melphalan, they didn't realize the melphalan was inert after an hour. You know, something was done wrong here. We would go back to IAC.
But since
the answer to your question is, I have one tumor in one eye out of something like, I don't know how many thousands, that didn't have a response to intra-arterial therapy, or specifically that grew. Sometimes the response isn't so obvious in a month. So it's really extraordinary. I didn't say they're all cured, but it's extraordinary. No, we see it all the time. I can't tell you how often I get called and said, we have this unusual patient who doesn't have an ophthalmic artery. And Pierre Gobin, our interventional radiologist, says to them, well, do they have an eye? Yes, they have an eye, but they have no ophthalmic artery. That's a call I get every 10 days. When they come to New York City, they suddenly grow a blood vessel.
So how often does IAC work when IVC fails? Any thoughts on this? Oh,
That's easy. I'll give you a number. We'll see what Carol says. We'll see what somebody else says. The answer is 95% of the time it'll save that eye. Now, we won't treat an eye with rubiosis, et cetera, and those are some really bad eyes. But no, it works virtually all the time, which is, however, the amount of treatment that you have to give an eye that has previously had intravenous chemotherapy is much more. You have to do much more focal therapy. But the answer to the question is you cure almost all of them. Carol, is that true?
So it depends on how advanced. Am I echoing?
Slightly, yes.
Yeah, not sure why. It depends on how advanced the disease is. For minor disease, IAC is successful most of the time. But when we did our study on IAC as primary therapy and then secondary therapy, here we're talking secondary therapy after IVC, we were able to save the globe in about 75% of cases.
This was a situation where 12 cycles of intravenous chemotherapy was performed elsewhere, and the child had bilateral recurrence where we performed bilateral IAC. So how effective IAC is for tumor recurrence following IVC or prior IAC?
Well, it's highly effective. That was easy. But isn't it an interesting phenomenon, and we've all seen this, in a patient with bilateral disease who seems to be pretty stable, doing well for weeks, months, and sometimes even years. And then they come in and they have 5 tumors that have grown. So we're not talking about just one tumor with a little edge recurrence. Maybe you didn't quite do the laser right. You're talking about, I don't know if you know what Miracle Grow is, but it helps my tomatoes grow. It looks like you've added Miracle Grow to the eye to make the retinoblastoma tumors, but all of them are growing. Can someone tell us why that happens? Guillermo, why does that happen?
I wish I knew.
But it's
I don't know, but this is a developmental tumor, so maybe the patient is in a stage of development that, you know, impacts their retina at that moment. I don't know.
Santosh, back to that. Can you go back to that case you just showed?
Mm-hmm.
Yeah, so that right eye, the top panel, keep an eye on that because you had a nice response after IAC, but this is exactly the type of tumor that can come back because it's over an ischemic bed of solid rock. So that's an eye that I would have, if I saw recurrence after IAC, I would irradiate that.
Yes. What about this? This was our own patient and there was no technical hitch at all. We did a perfect IAC. Our radiation oncologist is very good and interventional neuroradiologist is also very good. But Under our observation, after one session of IAC, there was increase in size. After the second session of IAC, there was further increase in size. So how do you explain that?
Go back to IVC. That's what we would do.
Right. So we went back to IVC, and then there was good response. But 6 months later, there was a recurrence, did not respond to TTT, and this is the only seeing eye. Then we did plaque, and finally it settled down. So it took IVC, IAC, plaque brachytherapy for this particular tumor to settle down. So I think we have about, we are just run out of time, I suppose. So I had a lot of questions, but I'm sorry I have to cut this short. So let's end this here and go back to Mritika for the quiz questions.
Yes, I'll just start sharing. Okay, so I hope all of you have registered, and if not, you can still do so. So there are exciting prizes to be won as well. Okay, I'll just come to the rules. So initially, I'll be asking you 9 questions, and these are related questions. So question number 1 to 3 are related. Questions 4, 5, 6 are related, and 7, 8, 9 are related. First 9 questions, they're not MCQs, but you need to write down the answer and message us. And each of these will have 5 points. If you answer all 3 related questions correctly, you'll be given 20 points. Post this, we will have 2 questions at the end of each session, and these would be MCQs. And for these, we have 10 points. So there'll be 15 seconds for each question, and this is an open quiz. Everyone can participate, and I hope you all do. Some of them are quite easy, and some are a little tricky, but exciting nonetheless. Okay. So you need to WhatsApp and SMS your answers. Just write down the question number along with your answer or the options A, B, C, or D. And you can send this to 8500452020. Please do not answer on the chat box, Facebook, or YouTube. We will not be taking those answers. And of course, the Quizmaster's decision will be final. Okay. So are you ready for it? Should we begin with the first question?
Mm-hmm.
Okay. So some of these questions also have pictures, and that picture may hold the clue for it. All right? Okay, here we go. So question number 1. In the 16th century, I lived where I heard ISO 2020 is being held. Name the place. Question 1, 2, 3 would be related. 15 seconds. Okay, moving on to the next question. Question number 2. Normally, I would dissect executed criminals, but I performed an autopsy on a 3-year-old child and have gone down in history as the person who described a substance that looked like brain tissue mixed with thick blood and crushed stone, which was the first case of something described in literature. What was it? Your time starts now. Okay, moving on to question number 3. And this is, who am I? The first 2 questions were related to this. Moving on to the next set, questions 4, 5, 6 will again be related. So here we have question number 4. I described fungus hematoides, a distinct entity, different from soft cancers occurring elsewhere in the body. I believed in the eyes of children, this tumor originated from. So you need to complete this sentence. Where did this tumor originate? Moving on, question number 5. I suggested enucleation as the treatment for retinoblastoma to save the life of the child. Who am I? And finally, the last question for this. Apart from retinoblastoma, I also happen to be the person who first described the natural cause of another intraocular tumor. Name the tumor.
I'm sorry to interrupt, but I would request everyone to send the answers back to back simultaneously and not take a break, because I think everyone's just writing down their answers and sending them together. So please don't do that. They won't be counted.
All right, so we'll move on to the next related set. Now we have question number 7. Now I'm going to play a clip, and I was one of the characters in this movie. How many Academy Awards did it win? And here we go. And I'll play that once more. I'm sure most of you would have guessed by now. Moving on to the next related question. I'm the only ophthalmologist to have run in the Olympics and won. Who am I? Please send in your answers along with the questions. Okay. Now I carried this in my pocket and it became the death of me. What was my best work and bane? As I said, some of the pictures have clues. All right, we'll come back with the questions again after each session. Let us now begin our main sessions. So for the first lecture, we have Dr. Ashwin Malipatna, and he is from the Hospital of Sick Children, Toronto. He has done extensive work on staging and classification of retinoblastoma, most notably the AJCC classification. Today, he will be talking about apples and oranges, or are we all on the same page? And for the discussion, we have Dr. Seema Das. She's a consultant at Shroff Charitable Eye Hospital, New Delhi. She's known for her calm nature and dedication to her work and is the best person to carry forward this discussion. I'll stop sharing my screen. Dr. Ashwin, you can please start sharing.
Yeah. Just can you all see my screen there?
Yes, sir.
Okay. So thank you very much for the opportunity. I think it's incredible to be able to present in India, even when you're not in India. And I think I'd like to take that opportunity to also extend my support to what India is going through right now, and hope things get better very soon. I want to improve on the title that I was given. It's not only classification of retinoblastoma that we're talking about, it's also staging. And there is an essential difference between the two. And we'll come to that as we go forward because it's part of the apples and oranges. There you go. So in 2005, when I was introduced to the classification of retinoblastoma, there was the A, B, C, D, and E that I was introduced to. And I was very categorically told that EIs are those that are unsalvageable, destroyed, or dangerous, and therefore suggested enucleation. I was a trainee at that time, and all of this just soaked into my head pretty easily and got embedded in there. So when I actually went to an ARVO and saw a poster that described tumors like this, but did not call it a group D, I was surprised for myself. And I learned that there are essential differences in the way the world talks about group Ds and group Es. And this difference was elicited by a great paper by the group in Memorial Sloan Kettering in New York. They compared the CHLA and CHOP versions and brought out essential differences between the two. And they found that it has ABCDE is described differently in different, let's say, different places around the world. And therefore, publications started to mention them interchangeably as group D and group E. But some of them can get very inconsistent and confusing to try and follow which group D or group E we're talking about. To elicit my point, I'd like to focus on a recent publication that in 2019, this publication was about preservation of group EIs with neovascular glaucoma. And in the discussion, they specifically talk about what they describe as the ICRB, which is group EIs as defined as such and such. Most of the definitions taken from the CHOP, but there are essential parts of that definition that have also been taken from another referral, which is the CHLA version of ABCD. So there are differences in the way these are described, and this paper seems to have amalgamated the two into one. So that brings up that aggravates the confusion that's out there in the literature. Another paper that I'd like to talk about is the one that is a summary of how IAC responds, and table 4 in that paper talks about A, B, C, D. And if you go back and look at each of these papers, the classification that has been used to call this A, B, C, D, and E are different in each of these papers. And in some of them, that's in gray, they described which version of the classification that's used. That makes data like this a little harder to follow and more inconsistent when it's published. The fact that these the versions of A, B, C, D, E are different across the world comes across quite well when you look at the reported high-risk pathology from each of them. And you can see that there are these essential differences in the proportion of high-risk pathology that present from similar parts of, or let's say, institutes that are performing in similar populations across the world. So how does it all matter? How some of us call it a little bit differently. How does it really matter? And to bring that point home, I'd like to give you a story from my life. This in my life, for the beginning of my life, was either called flip-flops, as it's called in Canada, or called Hawaii chappals, as we call it in India. And I was familiar with these two terms. So when I went to Australia and discovered that these are called thongs, I was very surprised because the instructions very clearly said, do not wear thongs to the driving test. And I did not think of flip-flops when I So that's just to elicit how it matters what you call something and what it reflects in our mind. Back to the question about apples and oranges. Is it the CHLA or the CHOP version that is better than the other? Now, we can argue for a long time about which one of those two is better, but I think the solution is different. And we proposed a solution, which was the AJCC Retinoblastoma staging chapter, which had a number of authors, many of whom are on this call as well. And the panel discussed questions about Group D and Group E, and the questions brought up were, can we generate an updated definition of what advanced intraocular disease is? Because we call these things different. Advanced intraocular disease is something that has a very variable definition, and which Group D or E eye is associated with high-risk pathology, which eyes fail salvage, and should we enucleate any of these eyes up front was the question that was presented. We look back at the specific entities of each of these staging systems or classification systems from across the world, and we decided to focus on those entities or those variables that were relevant to the current modalities of treatment and current modalities of, let's say, association with prognosis. So then we came up with the retinoblastoma staging system, which was the 8th edition of the 8th edition of the AJCC. This is the only evidence-based staging system. So we did start with the evidence and we worked our way down from there. We also, for the sake of evidence, we also looked at 2,802 eyes of 2,079 children. And, we were looking at all of the same features described, or the variables to tell us which way to go forward. We came up with a staging system that was very briefly this, which is T1A is a peripheral tumor, T1B is a small but tumor that's closer to either a disc or macula, or a larger tumor that does not have retinal detachment, which is a T2A, and vitreous seeding, which is or subretinal seeding, which are T2B. Advanced intraocular retinoblastoma is defined as T3, which were divided into A to E. That's for thicycle eye, tumor invasion of the intraocular pressure raised, hyphema, and aseptic orbital cellulitis. And T4 was defined as tumor that's outside of the eye, either overt or radiological alone. Of course, with the N and Ms, there are definitions about metastatic staging as well. So why bother using this staging system? Well, the staging system is different from a classification system. Stages go serially, which means the tumor progresses from intraretinal to intraocular to advanced intraocular and eventually extraocular. And that's the natural history of the disease. So this reflects that natural history better to tell us exactly where in time we've caught that. This also better defines that an eye might be a risk to preserve, and we are suggesting that some of the T3 eyes are potentially unsafe to preserve. This also manages to combine the grouping systems, which are IIRC, ICRB, and the staging system, which was the 2006 publication by Shantada, the IIRS. So we've attempted to combine these. So I think we need a system because we need to move away from the familiar but still unclear Group D versus E. And this is one system that's useful to ophthalmologists, oncologists, radiologists, pathologists, and geneticists. And that's the other reason why we need to go ahead with the system like this, a unifying system, with the introduction of H1, which describes hereditary traits, which is actually the best predictor of long-term prognosis well after retinoblastoma is treated. It also better defines high-risk features in histopathology, which I think Dr. Chavez Barrios might focus on as well in the subsequent talk. And for further reading, I would suggest the papers that have been published recently about how this staging system would pertain to prognosis. And if any of you are interested in a handout or a presentation, please click on that QR code and you'll be given one. So thank you.
Thank you, Dr. Ashwin, for this wonderful presentation and making the things a little more clearer. The retinoblastoma classification, especially the grouping system, sometimes can be very confusing and there are a lot of overlaps. So I would like to know your views on two aspects on the AJCC staging system. One is CT2, where which essentially is intraocular tumor with vitreous and subretinal seeds. Now, in the grouping system, we have subdivided that into C and D because we know the prognosis might be a little different, especially in our part of the world where we are still using IBC as the primary treatment modality. Right? So what is your view on this? Because in the staging, AJCC new staging system, there is no differentiation between the two, and they have been clubbed together. Second part is we have a validation study, and it does shows that the AJCC kind of confronts to the survival, and as the sort of clinical T increases, the survival tends to reduce. However, again, in the T4, which is extraocular disease, it has been clubbed to A and B based on the radiological as well as the external appearance. But we know that invasion of the optic nerve and the extent of the invasion does determine the prognosis vis-a-vis a orbital extension. And that's what we see routinely in our clinical practice. So what is your take, or maybe the take of the panel on that?
Okay. I'd like to take these questions the other way around, if you don't mind. So I'll take your second question first, which is the question about your study that shows that there are other factors that could be considered in describing the prognosis of orbital retinoblastoma. Is that correct?
Yes.
So if that is the case, then I would strongly encourage you to publish that evidence, of course. And once we've seen that, we would introduce this into future editions of the staging system. I want to state that this staging system was evidence-based, so we did not have enough evidence at the time at which that was published to introduce these things. But having anything that comes up in the future in literature will help us better the system to make it more fine-tuned to reflect different forms of extraocular retinoblastoma, and therefore maybe subcategorize T4 better in a way that you have described. So I strongly encourage more publications like that in such a way that we know which way to go forward from there. Now, taking your first question, which is the difference between a C and a D in the grouping systems, was the fact that one would be focal seeding and the other one would be diffuse. We did look at those 2,000 eyes, and we found that the difference between focal and diffuse seeding did not make a prognostic difference, either to eye salvage or to the salvage of or to life salvage. We are looking at it in different ways. Seeding alone is a factor, yes, but do we differentiate focal to diffuse seeding? I'm not all convinced, especially since the treatment modality is now intravitreal for seeds, and we usually that perhaps will change the chances of eye survival. And I think that wasn't reflected in the retrospective data that we had in 2017 when intravitreal was not so much in some of the patients that we had collected data on. So we're still looking, we're watching that space to see if we can do things better. But yes, I mean, this is an evolving system that will always have scope for improvement in some way, but we're relying on that improvement to come from published evidence-based guidelines.
Thank you. Thank you, Dr.
Thank you so much, Dr. Ashwin and Dr. Seema, for educating us regarding that. Dr. Ashwin, could you please stop sharing the screen?
Oh, absolutely happy
so
to.
So we move on to the next section of our quiz, and I request everybody to please send in your answers exactly at the same time, because we're not getting the answers simultaneously, and it's kind of confusing. So we start the next section, and I'm sure that the questions are way easier now. So I hope you guys enjoy. So the next question is question number 10, that is, identify the condition shown in the picture. A, retinoblastoma group E. B, choroidal metastasis. C, Coats disease. And D, retinopathy of prematurity. So question number 11, which of these cases is most likely to have intrauterine or early postnatal retinoblastoma? So over here you can see 4 pictures and your answer should be in the form of A, B, and C and D, depending on the picture you think is most suitable. So we move on to our next section. So Dr. David Abramson, the man behind most of our knowledge of intra-arterial chemotherapy, he's currently the Chief of Ophthalmic Oncology Service at Memorial Sloan Kettering Cancer Center in New York. And he's going to educate us regarding the indications and results of intra-arterial chemotherapy in 2021. And for the discussion, we have Dr. Mahesh Anmugam and the head of Vitreoretinal and Oncology Services at Sankara Eye Hospitals and the co-founder of RetNet India. He's known for his dedication towards retinoblastoma. Dr. Branson, you may share your screen, sir.
Hold on. Can you see it?
Yes, sir, perfectly.
Okay. Thank you for this opportunity. And I thought even more important than retinoblastoma is what's going on in India. So from those of us from outside of India, we're sending you a big heart. A year ago in New York City, we were a true disaster with bodies. They didn't have places to put the bodies, and it couldn't have been worse. And our hearts truly go out to all of you. And we got through it, and so has everyone else, but it was many months of awful. So yes, I'm going to talk about what I like to call chemosurgery for retinoblastoma. I'm going to talk about off-label use of drugs. As you know, there are no chemotherapy drugs approved in the United States for children. A comment about our retinoblastoma program. It's the world's oldest. We've been going for 107 years. It's been run by 3 physicians, Dr. Reese in the center, Dr. Ellsworth on the left, and a much younger Dr. Abramson on the right. We started at Memorial Sloan Kettering many, many years ago, have been around to many institutions in New York City, and in 2004, came back to Memorial Sloan Kettering. And since we've been there, we've done more than 20,000 examinations under anesthesia for retinoblastoma. The program is pretty well known. Probably the 3 things that it's best known for are the Reese-Ellsworth classification, the work we've done on second cancers in retinoblastoma. Remember when we started, everyone thought they were late metastasis, and the intra-arterial chemotherapy. And really, I could summarize this talk very well with the next 4 slides. In 2003, just before I moved to Memorial, published a paper on our experience at that point, and we were saving 86% of the lives and saving 4% of the eyes. So despite the excitement and success of radiation, in reality, considering all unilaterals were being enucleated and most of the bilaterals had some enucleation, we weren't saving very many eyes. And lo and behold, in 2019, when I wrote a somewhat similar article, we could point to patient survival of over 99% and ocular survival of 95%. And I don't think you're going to go very often in life from a 4% survival to a 95%. And everything we do from now on will be working up, I hope, from 95%. Miraculously, 90% of these children have 20/20 vision. Now, of course, the unilateral patients who have enucleation have 20/20 vision, so that doesn't really speak to our skills. But if you're a family member, it's quite encouraging. How did we do this? We did this simply by saving very advanced eyes. These are eyes with advanced disease. All of them I've followed for more than 10 years after intra-arterial chemotherapy, and all of those eyes were saved. The story of intra-arterial, I think, is well known by everybody. It was really first done by Algernon Reese. He injected chemotherapy into the carotid artery directly in the hope that it would go to the eye. We now know that almost nothing got to the eye, and he was simply delivering what we would call intravenous or systemic chemotherapy through the carotid artery. Far less than 1% of the carotid artery gets into the ophthalmic artery. And it was really Kaneko in Japan, here shown with me on a memorable boat ride. Carol and a few others were there, who developed the microcatheter looking like a Foley catheter and introduced the use of melphalan. And they had very good results, but it was not widely accepted or understood. And part of the confusion was that the eyes that had intraarterial also had external beam radiation and hyperthermia. So the eyes did well, which is good news, but it was hard to know the contribution of any of those. Some people thought it was actually all about the hyperthermia. It was hard to know. In 2006, Pierre and I introduced the modern technique being used with the 3 drugs you know. And I think you're all familiar with this. This is a cannulation, usually of the femoral artery, but by no means do you have to do that. We, Carol, and I think others have used other sites, as is done. The catheter is passed up through the abdominal aorta, through the thoracic aorta, into the internal carotid artery, and then just to the orifice of the ophthalmic artery, we can get a very nice angiogram. And here it is. And in May of 2006, with an IRB approval, we had patients scheduled for enucleation to whom we offered intraarterial chemotherapy. And here's the first case, very advanced disease, obviously. We did the treatment, we had chosen the doses, we hadn't done any animal experiments, and I'll get back to that a little bit later. And 3 weeks later, the patient came in. And we knew that the world changed in May of 2006. Interestingly, that child who's here next to me with her permission, at the age of 14, is pretty tall. As you know, I'm pretty tall, and I think she's going to be taller than me. This actually stimulated us to look at the growth patterns. With systemic chemotherapy, as you know, growth is affected, usually, but not always, the children catch up. With intraarterial chemotherapy, the growth is not affected, telling you that they really get trivial doses intravenous. Well, the technique's been adopted worldwide. I'm not going to bore you with all the details, and whenever I show this slide, I am out of date, but it has been done in more than 50 countries. But more importantly, everyone has been able to replicate the results we had. In the United States, it's done in all centers except St. Jude. This is just one of many really good papers by Carol on their experience with intraarterial chemotherapy, in which they conclude that it's safe and effective. Argentina was one of the earliest adapters of this technique. In 2018, they said it was safe with a low complication rate. And later on, their title said the whole story. It's more effective than sequential periocular and intravenous chemotherapy as salvage treatment. Switzerland has been a leader in recent years. I'm sorry, Francis Meunier is not on this. They have published a number of papers. And again, their title says what they thought. First line intraarterial versus intravenous chemotherapy in unilateral sporadic group D retinoblastoma, evidence of better visual outcomes, ocular survival, and shorter time to success with intraarterial chemotherapy. Italy was the second or third country to adapt this. They also said it was safe and effective. There have been many excellent papers from India, including a number of them in collaboration with Carol. And the conclusion there was the accumulated evidence shows that it's more effective in providing eye salvage in group D and E compared to conventional systemic chemotherapy. From China, many articles, I've been to China many times, and they are doing the exact same thing. They conclude that it is safe and effective with high success rate. From Chile, the conclusion was it was safe and effective and they were able to reduce enucleation rates. From Turkey, intraarterial and intravitreous were safe and effective. From Thailand, safe and effective. From Spain, an attractive alternative for the management of retinoblastoma. From Korea, safe and effective. From Mexico, safe and effective. From Sweden, safe and effective. From Pakistan, effective. From Malaysia, the same story. And there are a number of literature reviews, interestingly written by people who don't do it. This literature review in 2016 concluded that it provided minimally invasive, safe, and effective alternative approach. And just this past month, a review of 316 published articles concluded intraarterial chemotherapy is associated with high rates of globe salvage, low rates of serious complications. So the proof that something works is that someone else can do it. So when do we use it? Well, this is the question I get asked all of the time. 95% of all the eyes I see get intraarterial chemotherapy as first treatment, whether it's unilateral or bilateral. And as I mentioned earlier, I can assure you that my colleagues in referral base don't like to send me simple cases. We enucleate 5% of the eyes at presentation. This is true whether it's unilateral or bilateral. We use it as primary treatment for unilateral retinoblastoma, of course, primarily in group D and E. That does not mean we treat every single patient with E, as I alluded to earlier. And you save 95% of those eyes. And for primary treatment of bilateral retinoblastoma, you save 95% of the eyes. We always treat both eyes on the same sitting, one eye carboplatin-based, one eye melphalan-based. What about salvage treatment, which represents half the patients I see? They've already had intravenous chemotherapy and progressed. We save the same percent, but we require much more treatment because little bits and pieces are growing and give us problems. And really something for which I've gotten a lot of credit, but I don't deserve, is the observation that patients who recur, massive recurrence after intraarterial, or talking about retinal recurrences, if you treat them with 3 cycles of the exact same drugs, the exact same route, the exact same doses, which makes no sense, of course, you save almost all the eyes. And we publish that you save 83% of the eyes. Carol published very similar results. So the idea of going back to the same treatment that appeared to fail actually works. If there are no vitreous seeds, you can save almost all of those eyes. So let's just show you some eyes. All of these eyes were treated. Take a look at the retina. All of these eyes have driving vision in the United States. Thanks to my good friend Guillermo Chantada treating orbital invasion, we have progressed to use intraarterial chemotherapy for the orbit. Nothing but intraarterial chemotherapy here. As you know, we had demonstrated that topotecan given intraarterially gets into the optic nerve in very high concentrations. So we've moved to treat patients with optic nerve invasion successfully. What about eyes with retinal detachment? As was pointed out in the original classification in Group E, it was said that if you have a hopeless eye with no vision, it should be removed, which I think is totally appropriate. I did that for 30 years. But I come across families who will not take the eye out. So we began treating them, and lo and behold, 25% of the eyes with extinguished ERGs, afferent pupillary defect, no vision at all, regain some level of ERG function. We and Carol have pointed out that for deletion syndrome patients who are very difficult to treat with systemic chemotherapy, that it is a much better choice with intraarterial because there's far less toxicity, but those patients do have more toxicity than your average retinoblastoma patient. But what about patient survival? Because it's nice that we save so many of these eyes, but are we compromising life by treating these advanced eyes? In 2015, we collected 634 patients from New York, Philadelphia, Lausanne, and Buenos Aires. And of that, more than 99% survived and did not have retinoblastoma. And then in a larger paper, including New York, Philadelphia, Brazil, Switzerland, Italy, and Argentina, on 4,396 infusions in 1,139 patients, there were fewer than 1% metastatic retinoblastoma deaths. And remember that at least in the United States at the present time, patients who have primary enucleation of unilateral retinoblastoma develop metastasis about 4% of the time and die just under 2% of the time. What about second cancers? Well, we've eliminated the second cancers from radiation, as we did eliminate when we were doing systemic chemotherapy. We believe we've eliminated the second cancers from systemic chemotherapy. That's not only based on our data, but based on the more than 30-year experience using the same drug in Japan. And we've had no impact on pineals. You still develop pineals exactly the way you would develop them in those patients with the germinal form. And finally, just a really fascinating thing. I began this with an IRB approved study in humans. We did not do animals. We did not do laboratory tests. Since our publication and since everyone's experience, we and others have done primates, have done pigs, have done rabbits, and all of the studies are kind of similar, and they tell you that the dose that you're going to get in those animals is not going to be high enough. So if I had started with animals and we would have been discouraged by the results, I never would have done humans and wouldn't have had the opportunity to give this talk. Thank you.
Thank you, Professor Abrahamson, for that wonderful lecture. And thanks to you and Dr. Kaneko for getting us onto this bandwagon of intra-arterial chemotherapy, which has really revolutionized the way we treat retinoblastoma. As I mentioned earlier, we in India are at a disadvantage because of the costs concerned. So intravenous chemotherapy, I could do it for free or at the cost of about like $70 per cycle. In contrast to intra-arterial chemotherapy, which would be around $1,000 per cycle, which would be a bit difficult to for most of our Indian patients. I have a few questions. So is there any situation when you would not do intra-arterial chemotherapy?
It's an excellent question. And I want to emphasize that the decision of what we do with patients is a two-way street. What I mean by that is I could easily have two patients with identical disease where the family feels very strongly go one way or the other. I deal, and I know you do also in India, with a lot of patients who, given the choice of taking the eye out in unilateral retinoblastoma and having the patient survive, or leaving the eye in and having the patient die, choose to leave the eye in. That represents the majority of the world. It does not represent what we face in the United States, but it represents the majority of the world. So the decision of what you do isn't as simple as what can you do, it's what the family will accept. You know, I really don't like treating eyes with rubeosis, secondary glaucoma, etc. And I would say we almost never treat those eyes. Sometimes what you think is rubeosis is not exactly rubeosis, however. But if you think about it, the so-called high-risk features or higher risk features that we all worry about, I don't see any reasons to take the eye out. Those are not the disease. You don't die because you have choroidal invasion. You die because patients with choroidal invasion, massive or optic nerve invasion develop metastatic disease. By removing the eye, you accomplish nothing. We and some of the other people on this meeting have shown that you can eliminate choroidal invasion promptly with intravenous chemotherapy or intraarterial chemotherapy. It's not going to change whether it is metastasized. It's not going to change the patient outcome. But there's no reason to remove an eye like that. Similarly, in the optic nerve, you don't die because of tumor in the optic nerve. You die because what that tumor does and where it goes. So if you could treat it in the optic nerve and save the eye, including with vision, you'd be accomplishing something. I don't know if that answers the question.
So would you not make a distinction for massive choroidal invasion and an optic nerve invasion? The process of doing intra-arterial, is it likely to push it further outside in contrast to an intravenous?
Absolutely not. Absolutely not. First of all, if we took a poll here and asked how many people have seen choroidal invasion clinically, if we ask Patty, she'll say, every other day I see it. But if you ask the clinicians, how many times have you identified choroidal invasion? That is clinically. Santosh, how often? Once a year?
It's very difficult, but then on MRI scan, we can localize it. If we do a contrast enhanced MRI, fairly reliably, we can localize choroidal invasion and optic nerve invasion up to millimeters.
I completely agree, but my point is that the eyes with massive choroidal invasion usually have massive tumors. Not always, but usually do. So you don't actually ever see them clinically. You don't even know if they're there. The intraarterial will cause them to melt. That doesn't mean that they're not at a higher risk. Guillermo, do you want to make a comment about massive choroidal invasion?
Well, yeah, I think we have published that the natural history is about 3 to 4% extraocular relapse rate. And of those, about half can be salvaged. So that finally ends up in maybe 1 to 2% risk of death because of massive choroidal invasion. In cases diagnosed in Latin America, where the late diagnosis is usually more prevalent than in the US, and that could cause some genomic features that could make the tumor more aggressive.
By the way, we think with our cell-free DNA in blood, we can now separate which of these choroidal invasion patients are going to get metastasis and which are not. We know that most of them are not, and we know that some of them will. And the argument worldwide has been, do you want to treat all of them for that small group? And our cell-free DNA in blood, I think, is giving us the answer.
I have one last question. So what percentage of patients would need local treatment after the intra-arterial? What percentage you will not need a local treatment?
Yeah, that's really an excellent question. And unfortunately, it comes down to what the clinician likes to do and likes to see. So just because you do something and it works doesn't mean it was the right thing. Carol pointed out that their use of supplemental focal techniques is very, very infrequent. For our patients who start out with no prior treatment, I think our figure is 10%. But for the patients who have previously had intravenous chemotherapy and recur, almost 100% of them ultimately need some additional focal treatment. Now, that could include intravitreal.
Thank you. Thank you once again, Professor Abramson.
Thank you.
Now we'll take 2 questions for the quiz. The first question, which of these is a relative contraindication for intra-arterial chemotherapy? A, bilateral retinoblastoma, ciliary body involvement, C, optic nerve head involvement, or D, age less than 6 months?
The answer is E, none of those. That was easy.
Okay, we'll move to the next question. Which of the following is minimal exposure intra-arterial chemotherapy? A, reduced dose of the drugs. B, less duration of the drug administration. C, less than 2 sessions of IAC. Or D, less than 3 sessions of IAC. Okay. For our next talk, we have the master of the vitreous seeds, Dr. Francis Munier, the professor and head of oncology, pathology, and genetics at Jules Gondin Eye Hospital. And he will be speaking on vitreous and anterior segment seeds in retinoblastoma, what is hot in 2021. And a discussion for the same topic will be done by his own fellow, Dr. Nandan Sethi, who is currently a consultant at Tata Memorial Cancer Hospital in Mumbai.
So you're muted.
On the management of vitreous seeds in retinoblastoma, prepared by myself and Christina Statopoulos at Jules Eye Hospital in Lausanne. So for those who are interested, all what I will be talking about is treated in more depth in this paper recently published in Progressive Eye Research. So here's the synopsis of my talk. We'll first see what we are going to target with intravitreal injections. We'll also review the investigation tools I like to use in this context. We'll see the seeding regression patterns, the safety enhanced technique, then the drug regimen and number of injections. We will also touch how to avoid melphalan-induced chorioretinal toxicity, and I will end with my final recommendation. This slides to show you the three seeding patterns of retinoblastoma: class 1 or dust, class 2 or spheres, and class 3 or cloud. Now, importantly, I would like to insist on the fact that intravitreal injection can target not only vitreous seeding, but also retroyelloid seeding, as well as epiretinal and epipapillary seeding. Just here to remind the difference between vitreous and retroyelloid seeding. Of note, the fact that retroyelloid seeding is contained by the vitreous base, whereas vitreous seeding can, but not necessarily, project in front of the ora serrata, as shown also on this UBM picture, but is contained by the anter-yelloid, as you see here on the UBM of this montage. Now, there are several investigation tools I like to use for seeding. The first is optic coherence tomography, and the second is sonic biomicroscopy. And I just will review the main reason I use them. So in the operating theater, I use the Spectralis Flex, and for the UBM, I use the Aviso, preferably with a 50 megahertz probe. Optic coherence tomography is extremely useful to document early epipapillary or epiretinal seeding that is still invisible ophthalmoscopically. As shown here on this picture, you have, of course, seeding here in the vitreous, but you have seeds that are sitting on the optic nerve and even in the optic cup before and after intravitreal injections only. Now, optic coherence tomography is also instrumental in monitoring the seeding response to intravitreal chemotherapy. These are sequential pictures of the response at diagnosis of the seeding. You have here the seeding sitting on the retina, epiretinal seeding, and after first and second injection in the vitreous. What you see, what you observe first is a fragmentation of the spheres, followed by an increase in reflectivity. As soon as I see this increase in reflectivity, I know I can inject. I have to inject one more time, and this will be enough to get rid of this disease. Of course, and you don't have to necessarily wait to the complete response. of seeding, characterized by these 4 types, type 0, 1, 2, 3. You don't need to reach this point necessarily. As soon as you have the fragmentation and the hyperreflectivity on the OCT, you can stop injecting. Now, ultrasonic biomicroscopy is also instrumental because you want to make sure that your vitreous disease is not going to actually migrate through the hyaloid into the Petit's canal of the posterior chamber and be in the aqueous, because you're not going to treat efficiently a disease that is in the aqueous with vitreous injections. You will need for this also intracameral chemotherapy to get rid of the seeding. Now, regarding the safety enhanced technique, this is well adopted around the world with the paracentesis and the cryo of the entry site. Now, in terms of regimen, you have basically two drugs. You have melphalan, which is in itself proposed in 2 formulations, with propylene glycol, Alkeran, or without propylene glycol, Evomela, and the usual dose is 20 to 30 microgram. And you have also topotecan, more recently introduced, also with the same dose. And what I recommend for the number of injection is for dust, 2 injections, for class 2 or spheres, 3 injections, and for clouds, 4 injections. Now, these are the results you can get with a combination of intra-arterial and intravitreal injections. In this case, where you have also a cloud, not only in the vitreous, but also a retroidal cloud. Here, vitreous cloud, or here, subreal seeding and vitreous seeding treated by intra-arterial and intravitreal. Now, what about efficacy? This is quite amazing to see that melphalan is nearly 100% efficient. We have only 2 or 3 cases out of 250 that resisted to melphalan and required topotecan on top to control the disease. Topotecan, we don't know yet if it's as efficient as melphalan, but based on the publication of Rao in India, it looks like they had complete response in all the cases treated, but it was a limited series of cases. Now, in terms of toxicity, we have to acknowledge that melphalan is associated with a choroidal toxicity in nearly 40% of the cases, and whereas topotecan apparently has a very low toxicity, if any, and this has been also presented by Rao in his paper in 2018, and also by the New York group in 2020. Now, there is now a trial, a prospective trial with topotecan versus melphalan that is given for intravitreal injections to decide if it's as toxic and as efficient. Now, just to remind that toxicity has been graded 1 to 5. You have the reference here. And I think it's very important to use all the tricks to avoid high-grade melphalan-induced retinopathy. And here are two important tricks. One is to avoid paravitreal injections, and secondly, to limitate the final vitreous concentration to less than 10 microgram per ml. This is one thing to avoid is to inject in the Clockett's canal, as seen in this case, where you had a dramatic toxicity on the macula and the retina at the posterior pole. Here is also a major complication, grade 5, by injection in the retroyelloidal space, where you end up with this devastating effect. Now, a last thing to consider is the final concentration, which is dependent on age, the vitreous volume, and which is dependent also on the remnant tumor volume in these eyes. This is the formula, and so we end up with this ABAC showing the ideal dose you want to reach in the vitreous between 6, more than 6, but lower than 10 microgram, and we have also the advice regarding the dose to use depending on the tumor volume and the age. Now, my final recommendations to reduce the ocular toxicity is to perform a 10 megahertz ultrasonography to document the yelloid status and inject anteriorly to the posterior yelloid. To perform a clear cornea paracentesis with a 34 gauge needle to allow a lower melphalan concentration through a higher injection volume. To use a 33 gauge long needle, 3 to 3.5 millimeter from limbus, to inject and position the needle under the operating microscope, just behind the lens in the center, to avoid hypotony and other complication at the level of the intersegment, like uveitis and things like that. Avoid paravitreal, of course, injections by observing the cloud formation under the microscope. To use for axial lengths below 19 millimeter 20 microgram and not 30 microgram. That's just an example. Prefer meridian of a pre-existing chorioretinal scar, and to re-inject at the same meridian to prevent retinopathy extension. So with that, I thank you for your attention.
Yeah, so although Professor Munier is not present amongst us today for this meeting, I think on behalf of us all, I would express our gratitude to Professor Munier for especially reintroducing and popularizing this intravitreal chemotherapy, which has made a tremendous difference in the management of vitreous disease in retinoblastoma. In India, intravitreal chemotherapy has been adopted quite rapidly and successfully at many national centers. And unlike intraarterial chemotherapy, it doesn't need a specialized setup and is relatively much less expensive. As far as the drug selection is concerned in India, we tend to prefer topotecan as it is a much more gentle drug. Only in cases you do not respond to topotecan, we consider melphalan. In Indian children, we have seen that the toxicity of melphalan is much higher, and Dr. Honavar's group has published a paper in this on this aspect. Dr. Honavar also has, Dr. Munier has also mentioned how to tackle aqueous seeds, and a paper of intracameral chemotherapy has also been published. So I think I thank Professor Munier from all of us. Thank you.
Thank you, Dr. Nandan. Okay, so are we all ready for the next set of questions? Okay, so question number 14. Which was the first drug used for intravitreal chemotherapy? A. Melphalan, B. Carboplatin, C. Methotrexate, or D. Thiotepa? Moving to question number 15. Who amongst these was the first to describe intravitreal chemotherapy with melphalan for retinoblastoma? A. Munier, B. Shields, C. Abramson, and D. Kaneko. Okay. Now we have someone with us who's synonymous with ocular oncology. We have Dr. Carol Shields. She's the Director of Oncology Service at Wills Eye Hospital, Philadelphia. Her list of achievements is innumerable. She's at the top of the ophthalmologist power list and has also received the American Academy Life Achievement Honor Award. Today, she will be talking to us about what new am I doing in retinoblastoma in 2021. For the discussion, it gives me great pleasure to invite Dr. Rachna Mead. She has played a pivotal role in establishing ocular oncology unit at RP Center East. Dr. Shields, you can please start sharing your screen.
You are muted.
Can you hear me now?
Yes.
Okay. Thank you so much for this wonderful honor to speak at your Retinoblastoma Symposium. I have no financial interest or relationships to disclose. And I'd like to talk to you about Retinoblastoma 2021. What is new? First, I'd like to give credit to all of the collaborators on the ocular oncology service at Wills Eye Hospital who have helped in many of the studies that I will share with you. It truly takes a village to manage one case of retinoblastoma, and we have been doing this for over 50 years at Wills Eye Hospital. We provided in the Indian Journal of Ophthalmology a 2020 review of the modern treatment of retinoblastoma from Dr. Lazami, who's now in Monterrey, Mexico, Dr. Dalvin, who's now at the Mayo Clinic in US, and me. So I'll talk to you about three topics. What is new? It's all about chemotherapy. And I'll talk to you about chemotherapy for retinoblastoma, unilateral sporadic retinoblastoma, how to approach it, retinocytoma, what is the risk for transformation into retinoblastoma. So let's begin with chemotherapy for retinoblastoma. We all have our different tendencies for management protocols. We still use enucleation in Philadelphia for retinoblastoma if it's a no hope for vision or what looks like a high risk eye, or if the parents are unreliable or chemotherapy is not available. And we still use intravenous chemotherapy for bilateral retinoblastoma and intraarterial chemotherapy for unilateral retinoblastoma. Vitreous and aqueous seeds are treated with intravitreal or aqueous chemotherapy, and plaque radiotherapy is sort of our last go-to method if all of the above fail. So let me ask you 5 questions about intravenous chemotherapy. Does it work? Yes, it does. Do the results vary based on the International Classification of Retinoblastoma group? Yes, it does. Is it lasting to 20 years and longer? Yes. Do the results vary based on patient age? Yes. And what features predict recurrence? Well, I'll let you know. So regarding intravenous chemotherapy for retinoblastoma, it's used to treat the eyes, the brain, and perhaps even reduce systemic problems. Here we see a bilateral advanced retinoblastoma with total retinal detachment OU. Here is this same child She's now 20 years old and her vision is 20/30 OD and 20/70 OS, and she has no metastasis. She was treated in our first year that we used intravenous chemotherapy. But really, does it last for all patients? Well, we published this in the British Journal of Ophthalmology 2020, long-term 20-year real-world outcomes of intravenous chemotherapy in 964 eyes of over 500 patients. And if you look at these eyes and classify them according to group A, B, C, D, E, and follow them at 1, 2, 3, 5, 10, and 20 years, you can see at 1 year, most groups look pretty good. This holds for 2 years, and 3 years, and 5 years, and 10 years, and 20 years. So basically what you see at 2 or 3 years following intravenous chemotherapy is what's going to happen, what your outcomes will be at 20 years. So I usually tell patients what we see at 2 to 3 years predicts what they're going to have long-term. Now, how often do we need to resort to intraarterial chemotherapy or plaque radiotherapy in eyes that have received intravenous chemotherapy? Again, groups A, B, C, D, E. IAC is necessary in about 20% of cases, and plaque radiotherapy in about 20% of cases. The IAC at a mean interval of 5 months and plaque at a mean interval of 13 months. So generally, about 20% of patients will need these additional therapies to save the globe. Now, regarding risk factors for tumor recurrence following primary intravenous chemotherapy in the same cohort, we looked at this and published this in Pediatric Ophthalmology and Strabismus 2020. When does recurrence happen following chemo reduction, intravenous chemotherapy for retinoblastoma? Well, you don't have to wait for 10 years to see recurrence. You're going to find most of your recurrence by 2 to 3 years. So tight follow-up within the first 3 years is necessary in these cases. And who's at risk for recurrence? Well, using multivariate analysis, we found younger patient age at diagnosis, greater classification group, closer proximity to the disc, and the presence of subretinal seeds all predicted risk for recurrence and likely need for intraarterial chemotherapy. Now let's move on to IAC, intraarterial chemotherapy. It is a powerful, very effective treatment. You've heard David Abramson give his perspective on this wonderful addition to our armamentarium for retinoblastoma management. We find it best used in exophytic retinoblastoma, especially where you have an area that you can see that there's normal retina, because as the tumor regresses, you're left with a small scar, and in this case, flat retina, and maybe potential for some visual acuity. We're publishing a new report on retinoblastoma intraarterial chemotherapy in 341 consecutive eyes, over 1,200 infusions in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus this year. Here's an example of a very advanced eye in a 3-year-old boy before in plate A and B, and then after in C and D, showing beautiful regression of an eye that would have otherwise been enucleated. Looking at Kaplan-Meier outcomes for globe salvage, let's take 5-year follow-up. Group B, we have 100% globe salvage. C is 80%. D is 78%, and E is 55% globe salvage. Now, these groups D and E would have otherwise been enucleated. Of all the primary IACs, the 5-year globe salvage was 76%, and the median was 3 infusions of IAC, and in our hands, complication rate was only 1% per infusion. Now, a few words about intravitreous chemotherapy. We use this every week in our practice. And we like to use Evomila that Dr. Mounier talked about. This lasts for 4 hours, not 1 hour as the Alcoran lasts. And these are 2 different preparations of melphalan. Here you see before and after intravenous chemotherapy, And then after the addition of intravitreal chemotherapy, we're left with a macula and a clean vitreous. We published our outcomes in 192 consecutive injections where we had 100% intravitreous seeding control. And then later, Jasmine Francis did a collaborative effort where she had several centers contribute their results, and she found there were no extraocular seeding. There was no extraocular seeding in any case, and there was excellent control following intravitreous chemotherapy for vitreous seeding. I think for those of you who want further reading, Dr. Manjan Davida and our team wrote on the role of intravitreal chemotherapy in the Indian Journal of Ophthalmology just recently. Now, we also use precision intravitreal chemotherapy for localized seeding. What does this mean? Well, if a patient has just one little clump of vitreous seeds, we will inject the chemo precisely over the seeding using the indirect ophthalmoscope and visualization. So for example, here we see a vitreous seed sitting near the foveola. So we place the chemo right there in hopes that we don't create toxicity at the foveola. And you can see afterwards, the seed has resolved with little toxicity. So let's move on to our second topic. Second topic being unilateral sporadic retinoblastoma. How do you approach this? So previous publications have said that solitary unilateral retinoblastoma is somatic in 85% of cases and germline in 15% of cases. But it is way more than that, as it depends on the baby's age at presentation. So we looked at 482 consecutive patients with one tumor in one eye, solitary unilateral retinoblastoma, to ascertain the percentage with germline mutation. And we divided it and did a comparative analysis based on patient age. 0 to 1 year, 1 to 2 years, 2 to 3 years, or greater than 3 years at presentation. So if you look at this table, for those 0 to 1 year, 29% of children with solitary unilateral retinoblastoma had germline mutation, versus those that present over 3 years of age, only 9% had germline mutation, and this was highly significant. And then if you just look at children under the age of 1 year, those that were 0 to 3 months, 61% of them had germline mutation. This impacts how you might consider treating them. Compared to those 9 to 12 months of age, 22% had germline mutation, a highly significant p-value. So in table format, we see solitary unilateral retinoblastoma in the youngest age group, 0 to 3 years, has the highest risk for germline mutation. So you really have to anticipate multifocal tumors, bilateral tumors, pinealoblastoma, and other considerations for germline mutation. Whereas older children tend to have less risk for germline mutation. And we're publishing this in the Journal of Pediatric Ophthalmology and Strabismus. Last, just a few words on retinocytoma. What is the risk for transformation into retinoblastoma? To be published soon in 2021. All of us are aware of the clinical features of retinoma and retinocytoma. Benign appearing, they look like they're already previously treated retinal tumors in young children. So what happens if you follow these without treatment? So we looked at 78 tumors classified as retinocytoma or retinoma that we followed over 20 years. And we found in these 78 tumors followed over 20 years, at 5 years, 7% showed growth into retinoblastoma. At 10 years, 11% showed growth, and it did not increase at 20 years. Here's one such example. This was a patient who had been followed with what appeared to be a regressed retinoblastoma, i.e. retinocytoma retinoma, but then centrally there was growth. We treated her with intraarterial chemotherapy and she did beautifully. We would advise that all these children have tight follow-up when you first see them. We follow them in 1 month, then 2 months, then we make our interval 3 to 4 months, then Q6 months, and we follow them Q6 months for life. But now, based on this study, in general, if they don't show growth into retinoblastoma by 20 years, it's probably not going to happen. So we talked about in this short talk, what is new? Well, there are very different chemotherapy applications for treatment of retinoblastoma. Unilateral sporadic retinoblastoma in the youngest age group carries the highest risk for germline mutation, and retinocytoma retinoma overall has about a 10% risk for transformation into retinoblastoma. Oh, and one last thought, and this is credit to Dr. Chantada, gene therapy for retinoblastoma. He may make comments on this. Published with a team in Europe, the VCN01 adenovirus that targets cells with free E2F-1, which is a product of the RB1 dysfunctional pathway. It's been tested in mice and rabbits, and it's been now used in 2 patients, and I'm sure he can elaborate on this, 2 patients with retinoblastoma vitreous seeds. It worked, but it leads to vitritis. There's been no infection with the adenovirus, but there's a lot more to do and a lot more to learn. Here's 2 patients from his publication, 2 injections on day 0 and 14. And you can see the top case showing the vitritis and the difficulty in assessing tumor control. And in the bottom, we can see that these seeds right there did show a response following this adenovirus injection. But you know, that's not the first attempt at gene therapy. Dr. Patty Chevis-Barrios back in 2004 also had been working on gene therapy. I hope this is the future of retinoblastoma therapy. So I'll end with the comment I began with. It takes a village to manage one case of retinoblastoma, not just at Wills Eye Hospital, a village worldwide. And this includes all of us learning from each other. And over the past 50 years at Wills Eye Hospital, we have been learning and we continue to learn. I'd like to thank you for the opportunity to speak to you today.
Thank you so much, ma'am. Thank you for that wonderful talk. And we always look forward to learn from you and your talks. It's always a pleasure. So we all knew that the patients who present at a younger age are more likely to have germline mutations. And now specifically in unilateral retinoblastoma cases, your study has shown how high the risk can be. So I have a question. So if there is a child who presents at around 2 or 3 months of age with a unilateral group E retinoblastoma, so what would be the, according to you, what would be the best way to treat the child? Would it be enucleation upfront, or a systemic chemotherapy, or intraarterial chemotherapy?
So that's a loaded question. If it's a 2 to 3 month old with a group E, really advanced group E, we would consider enucleation. If it's a group E that is less advanced, perhaps no vitreous hemorrhage, but just a large tumor, and we can see an area where there might be, even though detached, some normal retina, we might consider intraarterial chemotherapy, knowing that the child might be at risk for other tumors. But for an E, we would not start with intravenous, we would start with intraarterial chemotherapy. Some children only get 1 tumor, 1 eye, even though they're germline mutation.
Thank you so much, ma'am. Thank you.
Thank you so much, Dr. Carol Shields and Dr. Rachna Amir, for the wonderful presentation and the discussion. We move on to our next section, of the quiz. So everybody, please get ready for the quiz session. So question number 16 is, which one of these is sustained release episcleral topotecan? A, periocular topotecan injection. B, slow infusion topotecan IC. C, chemoplaque. Or D, all of the above. Coming to the next question, question 17. Which tool is helpful in detecting cryptic retinal tumors? A. Ultrasound biomicroscopy. B. Handheld OCT. C. High resolution contrast enhanced MRI. D. The red cam. Moving on to our next session. So next is Dr. Patricia Chavez Barrios, who is an integral part of the prospective multi-center study by Children's Oncology Group on histopathological high-risk features and the role of adjuvant chemotherapy. And she will be talking on how does histopathology guide the management of retinoblastoma in 2021. And for the discussion, we have Dr. Swati Kalaki, the head of the Operation Eyesight Universal Institute for Eye Cancer at L.V. Prasad Eye Institute, Hyderabad. Ma'am, your audio, please.
Okay, can you hear me now?
Yes, ma'am, perfectly fine.
Okay. Well, it's a pleasure to be here with you today. And I'm talking here from Houston, Texas, from our Retinoblastoma Center of Houston. I have no financial conflicts of interest to report. So the outline of this talk is mainly based on what Santosh Hanwar asked me to talk about. And it's just how the pathology and the clinician communication is very important to have a successful evaluation of the enucleated eyes. How unsuspected retinoblastoma, sometimes it's very important the role of the cytopathologist to put the diagnosis in place. And our findings associated with higher risk for CNS recurrence came from the results that came from the COG study. So first of all, in the first question about clinician and pathologist, I think it's very important to have a interdisciplinary group to work with these patients, because we have heard throughout these talks the importance of all these different groups to have a successful treatment for the patient. So here in our group, what we do is to discuss all of these patients pre-treatment and also for follow-up. So for the clinical point of view, since we are in these meetings, we will know exactly the clinical presentation. Is this a typical presentation, an atypical presentation, primary versus secondary enucleation? So what I should look for when the patients are already treated, is this unilateral, bilateral? Exactly what are the concerns? Where is the tumor recurrent? How many chemotherapy rounds this patient has had? And if there's any questions in the MRI about the optic nerve, where exactly to look for. So this is really helpful for the pathologist. So I'll put an example. Here, our great ocular oncologist, Dr. Gombos, sees the patient and diagnoses this 12-month-old with that presented with leukocoria with a group E unilateral. So after discussion, and especially with the parents, with all the options, the decision was to do an enucleation. So I already saw this picture in the tumor board, and then at the time of the enucleation, I get the fresh tumor. Ideally, the first thing to do is to take the optic nerve margin so that you are sure you are not contaminating this. Now, optional, and that's what I do in our group, is immediately after cutting, I do a touch imprint of the margin that I just cut off. And then you can see here that is blood, the meningothelial cells, and not tumor. This is confirmed by the final histologic section. We also aspirate aqueous humor from the anterior chamber because we are undergoing these molecular studies, as we have published with Dr. Berry. And then we transilluminate. So we know exactly where to cut. And as we have published with the group of the International Retinoblastoma Staging Group, the guidelines for how to examine and manage these eyes, we do it under the microscope to select the viable tumor. So that's the one that we are going to harvest for genetics or treatment, research. Then we obviously confirm this is retinoblastoma by the cytology and that the tumor that we are submitting for studies is viable. After the fixation, we obtain the central PO section, which is the central part of the eye, and the two calottes, never transecting the optic nerve. And then from the calottes, we do this Brett Loffin. And in 4 cassettes, you get all these, the entire eye. Very important, and this part is the one that sometimes people don't do, is to do serial sections through the PO section so that you actually see the center of the optic nerve. So you have all these structures in here. So what are we looking for in histopathology? The higher risks for metastasis or recurrence is the extraocular extension, of course, then optic nerve invasion, post-lamina cremosa, and more than 3 millimeters of choroidal invasion. In this patient, we had a very well localized tumor into the retina and intraocular, just subretinal RPE invasion. This is not choroidal invasion. Peripapillary retina invasion, but not into the optic nerve. So this patient in our final diagnosis. So one of the things that the pathologist should do is confirm diagnosis. Okay, this is retinoblastoma, because sometimes it's not. And then in the next point, the important thing to do is to have the negative, the choroidal invasion of the optic nerve invasion, so that we can do the pathology part of the HACC staging. In this case, this patient has PT1, which is not invasive into the outside of the eye. The final stage is 1. And of course, we now include the H part, which is the hereditary. In this case, it was 0 because the study came back negative. And then in the interdisciplinary approach, we also counsel the patients genetically following these guidelines. Okay, so sometimes there are patients that have very atypical presentations. I'll quickly show you this one. I got a phone call from not a ophthalmologist, a hematopathologist working on a flow cytometry to rule out lymphoma. And she tells me, this is not lymphoma. I see a lot of cells. Can you please look at this? So this is outside in another state. So she sends the slide, only one slide. I see this. I see there's groups of large cells, calcification. So what do I know we need to do? I need to confirm what I'm thinking, which is retinoblastoma. Of course, we are talking about this, and I do the synaptophysin in the same slide. And this is just another case of retinoblastoma. More history, this is a 6-year-old female with retinal detachment that they thought it was Coats disease. And they went on and did a retinal drainage with 4 sclerotomies. And when they were doing the inferior one, they see this thick material. The surgeon thought it's lymphoma. And then he sent the vitreous. So of course, our final diagnosis in this case is retinoblastoma. Then this patient was sent for final treatment to our institution, negative workup for metastasis. So it was enucleated. We ink at the type of the surgery, the areas of the sclerotomy. And of course, this is a typical exophatic retinoblastoma, which is the most common one that is unrecognized and misdiagnosed as Coats disease. You can see the retina and the vessels will show up on the top, and the tumor is under the retina. So now here we confirm the same thing. Here is the retina histology under the retina. And in this case, the optic nerve is free. In the areas of the sclerotomy, the tumor is contained to the eye, no tumor in the sclera. And this is what you see in the real Coats disease. You see how the retina is pushed, and all of this can make a mass white looking because of the macrophages. And so this problem is always with a cytology interpretation when you have atypical cases, unsuspected. Now, in cytology, for us, these features are really different, although some people have trouble identifying this because they are not used to see retinoblastoma. As you know, you never, as ophthalmologist, if you know this is retinoblastoma, you are not going to biopsy. So the cytologists, they don't have experience with this. Retinoblastoma has this appearance of the rosette, is in children. Medulloepithelioma is also in children. Leukemia is in children. But lymphoma, as you know, many, many times more often in adults. Immunohistochemistry can help. You can do also the RB mutation staining, which will be negative because it is not present there. So usually these cases are the ones that present with cellulitis, anterior diffuse retinoblastoma, or Coats disease. And there are many published papers by many people here in the call that talk about the treatment after that. Now, to end my participation, we are going to talk about our findings in the prospective trial of more than 300 patients with unilateral retinoblastoma and histopathology. So why we are looking at this? Dr. Abramson made a very good point in his talk. You are not curing these patients by taking the eye that has choroidal retinoblastoma invasion or postlaminar optic nerve invasion. What you are doing is, of course, stopping the tumor to grow, but also at the time of our interpretation is predicting which patients may be a higher risk of CNS involvement or choroidal involvement. So for choroidal involvement, the thing that you will see, of course, the problem is not the choroid itself, is when it comes out of the choroid, and the vasculature that is going to drain is into the systemic circulation and the bone marrow mets. So these are more manageable, as we have heard and we will hear. But the problem is the optic nerve. The optic nerve goes into the brain directly or by the meninges and then recur. In this trial, what we found is that the combination of peripapillary optic nerve invasion, choroidal massive, and plony is worse. And just talking a little bit about post-treatment effect, you are not disappearing these risk factors at all. They were there. So even if you treat with intraarterial, with chemo, whatever, you are already treating. You should be treating beyond what a localized tumor is. Because this is already out, as Dr. Abramson pointed out, you are just identifying the risk, but it was already there. So the problem with these patients that have been treated for the pathologists is that this thing is mimicked disguised by the treatment effect. So here you have this regressed tumor by the macula. It appeared that it was almost consolidated, but okay, they couldn't see the optic nerve. You see the optic nerve here. It's full of tumor. Actually, the papillary area was negative. So there was no tumor in the inner part of the optic nerve. There was meningeal invasion. This patient recurred and died of disease in spite of all treatments. So our hypothesis is when you have this combination of this massive choroidal and clone, you have the tumor coming from the choroid through the perivascular areas in both ways into the meninges. And even if you clear your tumor any way you want, by surgery or by chemotherapy, the tumor is already in the brain. So in this conclusions of this trial is that the minimal choroidal invasion and minimal optic nerve invasion does not really need adjuvant chemotherapy. However, this combination most likely needs more intense adjuvant chemotherapy, as is where you were treating actually the metastasis that may already happen. And so, you know, with this stricter criteria, maybe you can have better prognosis of these patients. And finally, you know, this is a work of everyone together here in the Retinoblastoma Center of Houston. We work with all these people, and that's what we try to do, to have a multidisciplinary approach. Thank you very much for your attention.
Thank you very much for a wonderful talk, Dr. Barrios, and for wonderful pictures, of course. The histopathology pictures were just amazing. So I had a question as to, in your experience, have you seen that the patient has been enucleated and the histopathology has shown that the child does not have any risk factors for metastasis, but comes back with metastasis and you had to go back and do deeper sections? Have you had any experience like that?
Well, that happened to us in that COG protocol at the beginning of the protocol, when we were just looking at the submissions without deeper sections or anything, because that's the way we used to do it before this protocol had effect. And so, yes, then, you know, we look back, and the ones that had not put the calots in, they had massive choroidal invasion. Now, in our hands right now, as it is right now, we do all of these serial sections, we do the calots, and we have not had that experience so far with all these levels and all that. Now, there's cases of, we have had more than 3 cases of after intraarterial chemotherapy, the eye is taken out because of other reasons, retinal detachment, whatever. And then you don't find any choroidal invasion or signs or anything of optic nerve invasion, a little bit of choroidal scarring. And these patients had developed metastasis, some of them intracranial CNS metastasis. And I had almost studied the whole eye, and there's nothing in there.
I thought you were going to ask us to explain the eyes that have 0 higher risk features and develop metastasis, and that's even when the pathologist goes back and looks at it. And unfortunately, those are not as rare as we think. Anyone have an explanation for that?
Yeah, are you talking about primary enucleation or secondary?
Primary enucleation.
Primary enucleation. Yeah. You know, there's only a couple of cases that I can recall of, and not in my practice, but consultation cases. And, you know, I don't think it could be intravascular invasion, I don't know. But if you look really carefully, you'll find some of the high-risk features. Even
Dr. Barrios, I would agree with you. We had one case that developed metastatic disease, and we were told by our pathologist, Dr. Eagle, no high-risk features. But what he did was he went back, he pulled the calots, and then he found the high-risk features there. So in our experience, I think you're going to always have one of the high-risk features if you have metastatic disease.
Exactly. Yeah, I mean, you have to study. That's why we put that paper. You have to put the whole eye out and section it. Thank you.
Yeah.
I agree with Patty and Carol. It's very, very unusual, but in cases of secondary enucleation, we found a couple of cases that had metastasis without pathology risk factors. And what we found when we did the genomic studies that we published, I think last month, was a different genomic features in a different chromosomal alteration pattern, including 11q deletion, for example, in most of these cases, which were really puzzling. So we are now trying to, I'm talking about secondary enucleated dyes, which can be tricky. Even when we did all the calots, everything, and didn't find any pathology risk factors, but we found that genomically these tumors could be different.
Yeah, and in secondary, you know, the scarring can be very minimal. So it is very different than primary.
Yeah, I agree totally.
Yeah, thank you very much.
Thank you, Dr. Patricia and Dr. Swati ma'am. We will go ahead with the next two questions. Question number 18. Which of the following is not a recommended measure to get a long optic nerve stum during enucleation? A. Lateral canthotomy. B. Using tenotomy scissors. C. Using enucleation spoon. Or D. Complete transection of extraocular muscles. Okay. Next question, question number 19. Which of these is a clinical risk factor to prompt baseline bone marrow and cerebrospinal fluid analysis? A. Diffuse vitreous seeding. B. Tumor obscuring the optic nerve. C. Bullous retinal detachment. Or D. Iris neovascularization. Okay. Moving on with our next talk, we have Dr. Feiruz, who is recognized as one of the top 100 powerful women in ophthalmology in 2020. She has worked passionately in retinoblastoma in India and across the borders. She has proved herself as a successful healthcare entrepreneur and a passionate teacher. She will be talking on orbital retinoblastoma. How are we doing in 2021? And further discussion will be taken by Dr. Guillermo Chantada, who is an oncologist and hematologist from Barcelona, Spain, with his specialization in retinoblastoma, neuroblastoma, lymphoma, and histiocytosis.
Thank you so very much, Christy, for the kind introduction. I'm going to share my screen out here. I hope it's visible.
Yes.
All right. So at the outset, good evening to one and all respected teachers, mentors, friends, and colleagues. I thank AIOS and OPI for this opportunity and the kind invitation to be part of it. And I'm humbled and overwhelmed being part of, this particular symposia, international symposia, amongst the stalwarts in retinoblastoma. And thank you once again. So I'm going to talk about something which is very important as far as retinoblastoma is concerned, especially in the low-income countries, and that is orbital retinoblastoma, where we find advanced tumors. So it is challenging, but then over the past many years, we have recognized and realized that we can save them too. And we will see what we are doing in 2021 with orbital retinoblastoma. I have no financial disclosures or interest, and I extend my gratitude towards the patients and parents and my mentors who are in this platform as well, and especially my team who have been, thick and thin together, including the pediatric oncologist, radiation oncologist, and everyone in the management of these children. So I'll just, take you through a few cases. So what are the major challenges that we face in this part of the world is that, we get to see these advanced tumors, which has come out outside the confines of the eyeball. So this was a child who was initially diagnosed to have bilateral retinoblastoma, where the parents deferred the chemotherapy when it was advised, and the grandparents thought that traditional medicine would help. And this child was on traditional medicine for 1 year. So there are certain social beliefs in this part of the country that actually is a major challenge for us. And it has still not changed. It has not changed in 2021 so far. Yet another case, this is a 13-year-old girl who presented to me. This was just a year back. And initially, when she was 10-year-old, she was seen in a tertiary center with a retina specialist, where she was diagnosed to have traumatic cataract, subhyaloid hemorrhage, NVI, NVG, given treatment surgically as lens aspiration, past planar vitrectomy with multiple injection Avastin for the NVI, NVG. And then after a year, the child, presented in a regional medical college where she was found to have a staphyloma, where the eye was enucleated without, even having slightest of the clue that there could be an intraocular tumor. Enucleation was done. The pathology showed high-grade neuroendocrine carcinoma. The child was referred to another center for systemic chemotherapy, where they abandoned the treatment. So, this was how she presented. As you can see here, this is the implant which has been pushed, forward with an orbital tumor over here. In fact, we were thinking probably it could be an intraocular medulloepithelioma, a malignant variety, or a retinoblastoma, where, it has extended outside the confines of the eyeball. An incision biopsy was done, and then it was proven to be retinoblastoma. This is after 2 cycles of chemotherapy. So another challenge is clinical and pathological, misdiagnosis that sometimes we come across, especially in older children presenting with retinoblastoma, and patient counseling. The most important challenge in India, and I'm sure it's in Africa and South America, is the abandonment of treatment. And this is how these children land up with orbital retinoblastoma. As you've already seen, it's the extraocular extension of an intraocular retinoblastoma. Now, the prognosis of life salvage continues to be a concern in extraocular retinoblastoma, because this remains as the most important predisposing factor to tumor-related death. And in fact, the risk of systemic metastasis is as high as 10 times. And this is what the challenges that we face. Now, when we talk about challenges, I'm sure, Dr. Carol, Dr. Abramson, who, sees patient in the West, well, of course, the incidence is reported as less than 2%, but it's not the same. There is geographical variation in the presentation of retinoblastoma. And the main challenge in the low-income countries is the orbital retinoblastoma, where it is reported as high as 60%. Now, this is one paper that I recently picked up, and this is somewhere in Botswana, where they had reported. And when we talk about retinoblastoma, we usually talk about leukocoria as the presenting feature. Well, in their paper, 54% of the patients presented with proptosis, and it was orbital retinoblastoma. So it is indeed a challenge. In fact, intraocular retinoblastoma grows bigger, occupying the globe, leading to a proptosis. Then it comes outside the confines of the eyeball to reach into the orbit, extend into the optic nerve, and even intracranial extension. And these are patients that we come across in our practice, where it's so helpless once it has reached, a CNS metastasis and a CNS extension of the tumor. So in our practice, we classify it based on the presentation into primary, secondary, accidental, overt, and microscopic. Primarily, they present with an extraocular extension. Secondary, where there is an orbital recurrence after enucleation. inadvertent intraocular procedures where there is accidental perforation, overt where you actually miss radiologically and clinically of an extraocular extension, it could be a smaller one, and then microscopic, anything which extends extrasclerally and into the optic nerve. And what do we do? Well, this is exactly what we do in 2021, and this has been a practice all throughout. And Dr. Shantada has already, published the staging system of retinoblastoma, where a CSF analysis and bone marrow biopsy is done in order to stage it. So if it is just confined to the orbit, we call it orbital retinoblastoma. It could have a lymphatic metastasis also at that point of time to the regional lymph nodes. But once it is, there is a hematogenous or a CNS extension, then it goes to the stage 4. So now management of orbital retinoblastoma has been a challenge. From the conventional management, from these, publications and research which has been done, the mortality rate has been reported as high as 100%. Even with a combination of radiotherapy and adjuvant chemotherapy, it was found to be 70%. So our major concern as far as orbital retinoblastoma, where we see in low-income countries, is basically life salvage. So a multimodal treatment protocol with a judicious, implementation of sequential combination of chemotherapy, surgery, radiotherapy, it could prevent the systemic micrometastasis. And we have seen this in common cancers like breast cancer, GI cancers, and lung cancers, where there has been a multimodal treatment protocol which was proven to be, beneficial as far as improving the survival of these patients are concerned. So with the same backdrop, and I remember, this was something that was done when I was doing my fellowship with Dr. Santosh Unavar, and we had, looked into all these cases who have undergone the intensive multimodal treatment protocol. So basis of our treatment protocol is that high dose chemotherapy in order to, prevent the systemic micrometastasis, enucleation for a surgical clearance. If at all there is a microscopic, surgical residual, the external beam radiotherapy takes care of it, and then we do a high dose chemotherapy of 12 cycles. So when we talk about high dose chemotherapy, it is the standard, it is the vincristine, etoposide, carboplatin, which is the time-tested chemotherapy protocol that we use for retinoblastoma, but we escalate the dose of the same protocol, and that's why we call it a high dose chemotherapy. And why is it so? Because we always know that, once it's inside the orbit and involving the orbital fat and the muscles, it's impossible to have a surgical clearance, even if you do an exentration. You might have a residual orbital disease, which cannot be taken care by systemic chemotherapy. You might have to give radiation locally to take care of these surgical, orbital residual. And external beam radiotherapy alone wouldn't take care of systemic micrometastasis or metastasis. So there need to be a sequential combination of all these treatment modalities. So we looked into, the 40 patients, which is classified under primary, secondary, accidental, overt, and microscopic, of which 18 were primary. And then we found, when compared to other studies, the survival rate was very encouraging and promising, of 90% survival. So what did we do new in 2021? We again got a team of fellows who looked into the series, and we found that this was primarily done on primary orbital retinoblastoma. We had, multi-center additional cases, and we found that in 44 primary orbital retinoblastoma, at 82 months of median follow-up, we got 95%, 10-year survival under the survival analysis, and which has been very, very encouraging. So there was one case who had a systemic micrometastasis. So how do we go about it? I'm just going to take you through a few cases over here. Pre-treatment orbit, you can see the orbital extension, proptosis, 3 cycles of neoadjuvant chemotherapy. You can see the thysis bulbi over here, and it is at this point the child undergoes enucleation. Post-chemotherapy 3, in another case over here, you can see there is complete regression of the orbital component. When it's radiologically confirmed after the chemotherapy, that it's at that point of time that we go ahead and do the enucleation. Well, I'm just going to show this video over here. So what I want to highlight here in this video is nothing but, we don't go for exenteration. We don't take out the orbital fat, even in an orbital retinoblastoma. It's the same case that I showed you before where, she's undergoing enucleation after 3 cycles of high-dose chemotherapy after radiological confirmation of, orbital regression. So in fact, we don't even cut the muscles out. We preserve the muscles. In fact, some of the important steps that we take is wherever the orbital extension was found initially in the radiology, the tenons is taken along with it, and some amount of orbital tissue is taken to prove whether it's negative or positive. And one of the most important things, since I'm an oculoplastic surgeon as well, is that we don't leave the socket without implant. We, in fact, after a removal of the eye, and we place the implant, and most important thing in the surgical removal of the eyeball would be to get a large optic nerve stump. So we go deep inside, we strum the optic nerve, even in a thumbsical eye, and we try to get a large optic nerve stump. So again, going back to what I said, an implant is even placed after the removal of a thumbsical eye in an orbital retinoblastoma, because we all know that this child is going to get radiotherapy. There is a high risk for contracted a socket where you may not be able to place a secondary implant later, and this patient is anyway going to get the radiotherapy. So these are the certain things that I would want to highlight over here. So in this particular case, the optic nerve length that we could retrieve was around 22 millimeter, and she had a negative optic disc margin, post enucleation, radiotherapy, and the child is doing good. So as in the second case that I showed earlier, secondary orbital retinoblastoma, we don't even take the implant out. It's kept in place, treatment is completed, and this is how the child is. Optic nerve extension, again, up to the orbital apex. In fact, we had to give 9 cycles in this particular case for radiological evidence of regression of the optic nerve extension, and then enucleation was done, and the child is doing extremely well. So to conclude, the survival in patients with orbital retinoblastoma definitely improves with IMTP in our experience. So we chemoreduce, we confirm the reduction, we enucleate, we radiate, and we continue the chemotherapy. So this is what we are doing in 2021. We are able to save life in these children. Yet another child with orbital retinoblastoma was extremely happy with an artificial eyeball. Even after radiotherapy, he looks extremely well. So as far as research in orbital retinoblastoma is concerned, we have not done much from our side here, but then this is something which really I noticed recently, and we do have 2 of the authors over here, Dr. Shantada and Dr. Abramson, where they have found that, the recurrent somatic chromosomal abnormality in extraocular retinoblastoma, they found that the copy number alteration and the BCOR gene alteration is much, much higher in these patients. Well, I'm sure Dr. Shantada is going to discuss about, orbital retinoblastoma with me in the next 1 minute. So probably he might be able to tell us, how genetics can help us to predict, the aggressiveness of these tumors, even when it is intraocular, predict it, and how it could be applied in treatment in future. Thank you so much for your patient listening, and I'm very happy that most of our patients are doing well, no matter whether it's intraocular or extraocular, and thanks to all the parents for the support. Thank you so very much for the patient listening.
Thank you very much, Dr. Fairuz. It was a really nice presentation. I congratulate you for your results.
Dr. Shantada, you're not audible well.
So,
is it only me or? Yeah.
Oh, can you hear me?
Not
I can hear him.
audible.
We can hear. We can hear.
Okay.
Okay.
We can hear him. Yes.
Okay. All right.
Can you hear me better now?
Yes, better.
Okay. No, I was congratulating you. I was saying that your results are really impressive, and your presentation was really nice. So I think that orbital retinoblastoma is a very heterogeneous disease around the world. You are right, that is the most common form of presentation on retinoblastoma worldwide. And but in middle-income countries, we found that we have very few cases now with orbital disease, but when we have them, they are very aggressive. And then in the few ones that we could do the genomic studies, we found amplification of MYC, for example, and a very, very aggressive genomic picture in these cases. So it is interesting because our results in South America, at least, seem to have gotten worse, because now we have less cases, but the ones we have are very difficult to cure, even with intensive chemotherapy, with radiation, etc., as you've shown. So I think it's a very heterogeneous disease. And I just wanted to point out another treatment modality that I hear very commonly used in Uganda, for example, that is intraorbital injection of chemotherapy. Have you ever tried that? Have you ever tried injecting carboplatin or?
No, personally, I have not tried, Dr. Shantada. Well, in fact, I remember one of your case report where intra-arterial chemotherapy was used in one of the patient.
Yeah, we are going to talk about this in the next talk.
Right.
But I think I was impressed with the results with the intraorbital injection of carboplatin in the centers in Africa.
Never attempted.
Okay. Yeah. But I think
Guillermo, those cases in Argentina, are there primary involvement of the orbit that you have more problems, or secondary?
Yeah, they were primary mostly. They were these cases. I think one of them we knew had RB1 mutation, but MECAN amplification, and these cases were very difficult to treat for us. And the few ones we have an orbital relapse, they tend to do well, but the ones that present aggressively are very, very aggressive in the beginning. So
and Dr. Shantada, the paper that I just showed in the last slide that you spoke about the copy number alterations. Well, I'm sure research, it is a breakthrough thing, but how can we apply it clinically?
Yeah, these are still quite descriptive analysis. I think they will be very interesting to confirm, but probably when liquid biopsy becomes more available and we could check if these features can be detected preoperatively, could be of interest. What I can say from that, from those results, are if you find MECAN amplification, that is very, very bad prognosis. So these cases are going to do very, very bad, and it's very difficult. They are very difficult to treat. And when they get to the orbit, they is really very difficult to treat. We found, however, a number of cases with 11q deletion in secondary metastasis and orbital disease, which interestingly tend to do well and tend to respond to the chemotherapy. They have been refractory when they were intraocular. That's a paradox. I think that's a niche-dependent chemo refractoriness. But they tend to do well. But these 11q deletion cases are seen in neuroblastoma, for example. So they are also found in these late occurring relapses. And but so far, I think it is still quite descriptive. We have to take care of MECAN amplification. In our setting, perhaps BCOR mutations. These patients should still be studied more deeply. And it's probably a consequence of delayed diagnosis. So because we give the tumor more time to acquire these alterations in the chromosomes, and then they become more aggressive, and then you need a more intensive treatment to cure them.
All right. Thank you so much, Dr. Shantada. Thank you for
thank you. Your presentation was great. Congratulations.
Thank you very much.
Dr. Feroz, can I have a question?
Yeah.
So you showed in one of the cases where there was optic nerve thickening that it took almost 9 cycles before it could be documented on imaging that the optic nerve thickening had actually gone away. So I was wondering, because after chemotherapy, the imaging, how much can you actually rely on the imaging? Because post chemotherapy, there are also a lot of orbital changes. So do you keep on continuing with the chemotherapy till you have an imaging documentation of, the normal optic nerve thickness, or so that would mean a number of imagings for that
Yes.
patient,
Yes,
right?
Dr. Meal. Yeah. So for us, confirmation of regression of orbital retinoblastoma, be it orbital extension into the fat or even the optic nerve, is completely based on imaging. So what we do is we give 3 cycles of chemotherapy. After the 3rd cycle, the child undergoes MRI with contrast. And then again, if there is regression, we go ahead with enucleation. If not, we continue another 3 cycles until it is radiologically confirmed. So there is no other way that we resort to confirm the regression. We don't go and take a biopsy because it's impossible, right? It's a very diffuse disease in the orbit, and you're not going to go to the apex and get a biopsy as such. So we completely rely on radiology for this. Yeah, nothing else. Yeah, nothing more. Thank you.
That's what we did until cell-free DNA, and without telling secrets, what we're talking about monitoring, you can actually monitor in blood now. And some of the features that Guillermo pointed out in that paper, we actually get from our cell-free DNA up front on day 1. So we actually know if they have some of these genetic abnormalities, which is probably the most important thing.
Okay. Agree. Thank you so much, Dr. Pramsin.
Thank you so much, Dr. Fairoz and Dr. Shantada.
Thank you.
Moving on to the next set of questions. Which of the following may not be a predisposing factor for orbital retinoblastoma? A. Inadvertent perforation during enucleation. B. Clear corneal cataract surgery in an eye with unsuspected intraocular retinoblastoma. Fine needle aspiration biopsy in an eye with unsuspected intraocular retinoblastoma. Or D. All of the above. Question number 21. Unequivocal features of microscopic orbital retinoblastoma are all of the following except A. Full thickness scleral infiltration. B. Only skip lesions at transection site of optic nerve. C. Massive choroidal invasion. Or D. Contiguous optic nerve sheath infiltration. Okay, moving on to our next session, I would like to welcome Dr. Natalia Grigorovsky. She's a pediatric oncologist at Rio de Janeiro, Brazil. And today she will be talking to us about metastatic retinoblastoma. Is there hope in 2021? For the discussion, we have a pioneer of medical protocols and radiation techniques for ocular tumors, a brilliant academician, philanthropist, and clinician. We have Dr. Vijayanand Reddy. He's the Director of Oncology Services at Apollo, Hyderabad.
Just one clarification. We are going to present together, Natalia and
okay.
I'm
Dr.
going to present
will also be joining us.
the first part. Yeah, and then Natalia will discuss the following case. Sorry.
Okay.
So can you see my screen?
Yes.
Okay. Just well, let me. This presentation is going to be about: is there any hope in metastatic retinoblastoma in 2021? And I'm going to try to convince you that I think there is. These are the results of the COG, the most recent COG study, where some centers in India also participated, and it's there. Hopefully, are going to be published this year, where patients with systemic metastatic disease have around 80% survival rate. When they don't survive, it is because of CNS metastasis, and in the late event that you see here is about the second malignancy. But you can say that with intensive treatment, autologous stem cell transplantation, around 80% can be cured, and these are results including centers in middle-income countries as well, not only in the US. However, the picture is dismal when you see the patients that have metastasis to the CNS. Here, what we tried to do in that COG study was, as we do for other CNS tumors, is to increase the intensity of systemic chemotherapy to its highest level. That is giving very high dose of chemotherapy, then going to autologous stem cell transplantation because this chemotherapy is myeloablative, and then sometimes even radiation therapy. But even when we did that, we were only achieving around 15% survival rate. So in 2021, we can say that these patients with stage 4A, those are the ones that have metastatic disease outside the CNS, have around 80% survival rate with high dose therapy. So we are doing quite fine with those cases. There is a lot of hope. We can still improve, but when they relapse in the CNS. When we treat patients with stage 4B, the relapse rate is very high. Their event-free survival and overall survival is no higher than 15% everywhere in the world. And most centers in the world don't have transplant. So we have to find new treatment strategies for these patients. So I go back to what Patty has said about the dissemination of retinoblastoma and take that picture that we published in that paper, in this paper with Brenda Galli a few years ago, where retinoblastoma, as you all know, disseminates through the optic nerve, and that is a major way of dissemination of the optic nerve. Also, these are the results of a study we did of the minimally disseminated disease, sorry, where we found that when CSF dissemination occurs, it occurs isolated to the bone marrow. So it is an event that is highly in one compartment, in the CSF compartment. The systemic compartment is almost always free of disease when this happens. So we did that in animal studies as well. We injected animals with these cells coming from our patients and saw exactly the same dissemination pattern. The tumor first in the eye, then in the optic nerve, then to the brain, without overt metastatic dissemination outside the CNS. So these are the conclusions. The CNS invasion remains uncurable. High-dose systemic chemotherapy did not improve the outcome. Dissemination is mostly through the optic nerve, and systemic dissemination can be cured with systemic chemotherapy. So now we have two critical targets that we are not reaching adequately. These are the optic nerve. As Dr. Abramson showed previously, these are the results that we did in our research. This is in animals. So you can see that if you use systemic chemotherapy compared to intra-arterial chemotherapy, the exposure that the intra-arterial chemotherapy gets to the optic nerve compared to the systemic chemotherapy treatment is around 3,000 times. So whenever you give intra-arterial chemotherapy, the optic nerve gets 3,000 times more levels than what it gets when you give it intravenously. And let me go back to the concept that systemic intensive chemotherapy cures systemically disseminated disease. So the only way we have to treat the optic nerve with higher dose of intensive chemotherapy, it's not systemic chemotherapy, it is intra-arterial chemotherapy. And the other target organ is the CSF. It is proven by many pediatric oncology researchers that intrathecal and intraverticular chemotherapy work in not only in retinoblastoma, but in other CNS tumors and in acute leukemia. And there is a paper from the Toronto group more than 10 years ago when they used topotecan for intraventricular injection in a case with disseminated CNS disease, and it was safe and effective. And on the other hand, the drugs that we pediatric oncologists use for leukemia don't work. So don't try methotrexate and cytarabine. They usually don't work for CNS dissemination for retinoblastoma. So with that said, we discuss in Latin America this, what we call the triple therapy, target with this rationale in mind. And so the best way we could find some hope to treat these kids would be to give intra-arterial chemotherapy with systemic dose of chemotherapy. These eyes are not going to be saved, so you can give very high dose of intra-arterial chemotherapy, intravenous chemotherapy to take care of the systemic dissemination, because these patients usually have concomitant systemic dissemination at the beginning, not then at the relapse, and then intrathecal chemotherapy in a combined fashion. So with that, we published a paper a few years ago with a case that did very well with this approach. And now Natalia Grigorovsky is going to show you another case she treated with this philosophy, and try to think if this could be probably something that could give us some hope for the treatment of metastatic disease. So thank you for your attention, and thank you again for the invitation to participate in this meeting. So I leave the screen to Natalia.
You are muted.
Natalia,
Oh, thank you. Thank you. Can you hear me?
Yes.
Yes, very well.
Oh, sorry. Hello. I would like to thank you a lot for this kind invitation to share this challenging case that we treated in National Cancer Institute in Rio de Janeiro, Brazil. And this young lady was 33 months old, and she had initial leukocoria, proptosis, painful unilateral orbital mass, general weakness, and weight loss. Her lag time was 18 months, and she had neovascular glaucoma and periocular inflammation. And she performed, and she was submitted to an orbital biopsy, which was initially inconclusive our ophthalmologists in our institution. And these are her initial images, which had her family's permission to be shown. And this is her initial MRI images, which showed extraocular extension of the left eye with optic nerve involvement and intracranial extension to the chiasm. Then we proceeded an optic nerve biopsy by our our radiologist, and we could confirm the diagnostic and the RB diagnosis, and her molecular studies were possible due to an international collaboration with Dr. Guillermo group, and could show 2P gain, 6P gain, 16Q loss, and 70 gain. And her initial studies were negative, and she was staged by 4B. Her initial management with this multimodality approach was systemic intensive chemotherapy, and her first cycle was based on COG strategy with cisplatin, cyclophosphamide, etoposide, vincristine, plus intrathecal topotecan. And based on this previous paper already mentioned, we gave her high-dose intraarterial chemotherapy through external carotid artery infusion to target the orbit, because she had her ophthalmic artery was destroyed by tumor with carboplatin, followed by infusion through the anterior cerebral artery to target the chiasm with also carboplatin. This procedure was technically feasible, and we did not use the occlusion balloon because we did not have this kind of catheter in our institution, and it was without complications. We gave her the second high-dose intraarterial chemotherapy, but this time with melphalan and carboplatin, and the second systemic intensive intravenous chemotherapy with intrathecal topotecan. And after the third high-dose intraarterial chemotherapy, she developed this complication with periorbital edema, but it responded to the steroids treatment. And then we gave her the third systemic intensive intravenous chemotherapy. And I want to mention that she had this MRI lesion, inflammatory one, without any clinical manifestation. Then she was enucleated, and the histopathologic analysis showed complete tumor necrosis. And then she had her last systemic intravenous chemotherapy and intrathecal topotecan, and more 2 applications in a total of 6 applications of intrathecal topotecan. And at the end of treatment, she was received a sternal-beam radiation with 46 grays to orbit and chiasm. This is the image of her radiation programmation. And this is her after 1 year and 3 months follow-up in her last MRI images. And she's doing fine without evidence of disease. Thank you.
Thank you very much, Natalia. So this would be the third case we know that has been treated with this treatment. So we would like to provide these examples like possible hope for these really, really difficult patients to treat. So thank you very much for your attention.
I have a question. How are they doing neurologically after those treatments, comparative with other aggressive intracranial therapies?
Natalia, would you like to comment on your patient?
Yeah, she's doing really fine. She's okay. She's great. No deficit. She's fine.
As you know, in the United States, this is a pattern we see once every 15 years. It's that rare, despite the fact that it's very common throughout the world. And at least 93% of our patients have widespread metastatic disease, and the orbit is just the tip of the iceberg. But it's worth mentioning that some of these orbital diseases actually metastasize to the other orbit in unilateral cases. In other words, it's clearly not extension from the eye, it's hematogenous disease that comes back to the eye. And this is exactly what happens in breast cancer. When breast cancer metastasizes to different organs, it takes on a different molecular signature. And then when you have recurrences in the chest wall, and you think, well, we just didn't cut out enough or do enough radiation, it turns out those are metastases that have returned to the chest wall from the brain or from the bone marrow. So this is the challenge we face when we see patients, which is why local treatment for us is great locally, but it doesn't cure patients.
No, but our rationale here is that this is a systemic disease that can be controlled, but what cannot be controlled is the local dissemination to the CNS with systemic treatment. So the way we found to try to control, we don't know, it is just a few cases yet, is first to try to target the source of the dissemination of the tumor, which is the optic nerve. So by doing intraarterial chemotherapy, we give a mega dose to the optic nerve of chemotherapy. Every intraarterial is higher dose than a transplant for the optic nerve. So are we giving 4 transplants in chemotherapy to the optic nerve, and then target the CSF? I think ideally would be with intraventricular chemotherapy, and I hope that could be more rational to only increase systemic chemotherapy, which we know we failed already. We cannot increase intravenous chemotherapy anymore. We already gave the highest dose, and we cannot give CNS radiation therapy. We can, but as Patty said, probably the neurological outcome is not going to be satisfactory. So perhaps this can, if we can if we can cure 40% of the patients, I think that would be a great advance. I don't know if that's going to be that, but probably this is the way we are trying to go in South America after these few cases, right?
And how did you choose to increase the dose of carbo but not melphalan? All because of bone marrow toxicity?
Yeah, that was because of bone marrow toxicity and previous literature, because we found that this has been up to 200 milligrams. It was given for CNS tumors. So we know that that is not going to be too toxic to the CNS.
Dr. Shanta,
how long, for how long have you followed up the longest of these patients? I didn't catch that.
1 year and 3 months.
Right.
1 year and 3 months.
Excellent. This is Dr. Reddy from Hyderabad. Very interesting cases, Dr. Chatanda and Dr. Natalia. Very, very interesting approach. Most of you have mentioned about breast cancer in this ophthalmic meeting. So where you have a systemic disease and you target initially with intravenous chemotherapy, and there are publications on dealing with the primary disease. Once the disease is systemic, dealing with the primary disease has not increased the overall survival. But nevertheless, this looks very interesting to understand that you are getting a good local control. I hope that it transforms into systemic control as well. Our unfortunate experience has not been that great with these patients, especially patients with intracranial extension and CSF positivity. Honestly, we have never tried intrathecal topotecan, which is something which we should try after listening to your presentation and the result that you have shown. Probably intrathecal topotecan might be of great hope to these patients, because whatever that we have done intrathecal triple drug chemotherapy, we had CSF negativity after the treatment is being done after 4 weeks or 5 weeks, and even after that we did consolidation for another 2 doses of intrathecal chemotherapy. But in spite of that, these patients had recurrences and the results have been very, very poor. So initially with the high dose intravenous chemotherapy followed by external beam radiation, very precise and high dose radiation that we deliver, including this chiasm and intracranial lesions. But still these patients do not do well. But patients presenting with metastatic RB at the time of initial diagnosis has always been a poor prognosis. However, patients without CNS involvement had better DFS compared to CNS involvement, as I'm sure all of you agree with us with this. Similarly, patients presenting with CNS involvement at a later date also had very, very poor outcome. It could be anywhere, CSF positivity, and patients come with drowsiness, neck rigidity, and not playing and not eating. And then some patients have parenchymal metastasis in the brain or meningeal involvement. The outcome is very, very poor. Patients presenting with metastatic disease other than CNS, for example, lymph nodes, bone, at a later date after the initial treatment, they have a better DFS compared to CNS. I'm sure all of you agree with this. These patients do really well with the systemic chemotherapy. Again, honestly, I agree that we have not done bone marrow transplant, in autologous bone marrow transplant in these patients. mainly because the financial issues and also the poor performance status of these patients. We never done autologous bone marrow transplant. Even after complete remission, we are supposed to do autologous bone marrow transplant to have a longer DFR or a cure to be expected. But even with the systemic chemotherapy, these patients are doing well. I cannot quote a large series, but we have reasonable patients who had presented with systemic disease with bone mets and soft tissue meds and lymph node meds. They have complete remission and they are really doing well. Patients may be re-challenged with carboplatin etoposide as a systemic chemotherapy. That's what we normally do. If the DFS is reasonably longer, maybe after a year or two or after 4 or 5 years, they come back, we do systemic chemotherapy with carboplatin and etoposide. Ifosfamide is another drug which we call it as ICE chemotherapy, as a salvage chemotherapy. It has reasonably good results. I think that ifosfamide is better than cyclophosphamide in terms of response rates in these kind of patients with a disseminated disease. So the longer the disease-free interval between the primary treatment and metastasis, the better the response, I would say. So we have gratifying long-term controls in these kind of patients. But it's very, very interesting to know that intraarterial chemotherapy plus intravenous chemotherapy in these patients showing good results. So we would probably look at it. But intraarterial chemotherapy with such high dose of carboplatin, I'm really surprised that you carried on in good number of some patients, of course, but we need to see the long-term results in these patients. Thank you. So I really congratulate you guys, and you have shown us some new areas how to deal with these patients. We would certainly consider in our institute. Thank you very much.
I have a question. Can I?
Thank you, Dr. Vijay. Yes, please.
Yeah. Mritika, can I go ahead with one question? Yeah, so this is to Dr. Shantada and Dr. Var. So when we talk about CNS disease, especially when it is meningeal, what is the longest duration of relapse that you have seen in these children?
They relapse very, very soon. In my experience, they relapse between the 6 months and a year. These are very, very quick relapses. That's
so since your case was 18 months, right? One and a half years, right? Yeah. Would you consider it as disease-free?
We hope.
Okay.
We hope.
Yeah, most of them would come back within 6 months to 1 year. So the CNS relapse are very fast, and they do very badly. But if they have met somewhere in the parenchyma of the brain, that's usually a little late, and they could be 1 or 2, and those patients can be salvaged with stereotactic radiation without any systemic relapse if they have a parenchymal lesions.
Okay. Would you consider gamma knife surgeries in these patients, Dr.
Yes, that's the stereotactic radiation can be given by photon or gamma knife.
Okay. What would you prefer, as a child is growing?
Both are actually similar. Where very few centers you have gamma knife, but nowadays stereotactic radiation with X knife is easier and less invasive.
All right. Thank you so much. It was really enlightening. Yeah, thanks.
Thank you so much for sharing your experiences with us. So we move on to our next section, to the quiz part, of course. Question number 22. Which of the following is the most significant risk factor for distant metastasis? A. Optic nerve involvement. B. Massive choroidal invasion. C. Extrascleral spread. D. Anterior segment seeding. Moving on to the next question. Question 23. Which of these is the retinoblastoma relapse classification? A. RSU. B. RVC. C. LMN. D. COG. I must say that most of you are doing pretty well at the quiz, and Please keep it up. So we move on to our next section. Dr. Usha Kim, the head of the Department of Orbit, Oculoplasty, Ocular Oncology, and Ocular Prosthetics at Arvind Eye Hospitals, and the president of Oculoplastic Association of India, is currently working substantially on genetics and retinoblastoma, and is talking on how can genetics help in the management of retinoblastoma in 2021. And for the discussion, we have Dr. Vikas Khetan, a young and dynamic vitreoretinal surgeon at Shankara Nethralaya, Chennai, who has also worked on ocular oncology and ocular genetics and has added to the pool of knowledge available to us. Over to you, Dr. Usha.
Is it visible?
Yes, ma'am, your screen is visible.
Yeah. So thank you. I think that's the last talk for the day. Not a topic that's that many people are fond of, but I just like to emphasize because this has a lot of implications on the outcome and management of the retinoblastoma. So it's very important that we include genetics, and it has been included as part of the staging as well at this point of time. So let's do a little basics. Retinoblastoma is caused by the neural retina specific alteration of the RB1 gene, and inactivation of both the alleles are necessary for the retinoblastoma formation. Now, tumors are caused by genetic aberrations. That is, the retinoblastoma tumors are caused by genetic aberrations, but that does not mean that all patients inherit the disease, and does not mean that tumor in all cases are heritable by the next generation. Some tumors are caused by RB1 mutation, others by amplification of the MECN gene. This is introducing you to all the terminologies and the genetics. Now, looking at, I think we'll have to shift our focus to the heritable and the unilateral and bilaterality. So, heritable retinoblastoma has a high risk of other cancers, increased risk of RB in siblings and offsprings. Usually, alterations are identified in blood. And the non-heritable entity has no risk of other cancers, reduced risk of RB in siblings and offsprings, and usually alterations are identified only in the tumor. Now, with our 1,500 cases over the past 20 years, we took up 450 probands for genetic analysis along with their parents and siblings. So we established the stepwise method for the RB1 analysis. One, we did the Sanger sequencing for the known point mutations, which is already existing in literature, 90% somatic and germline. Then we went ahead and did the MLPA for the deletions and duplications. Then we did the MS-MLPA for the somatic changes. And this has been published also. The next thing we went about doing was the next generation sequencing facility, which helped us identify the new pathogenic variants, which could not be identified by the conventional methods. So overall, we saw about 20 new mutations, which was novel to our population. And of the lot, we saw about 38% showing a nonsense mutation, 20% deletions. And then we did have some missense, and we also had other indels and splice mutations, which were also a significant number. And the timeline we took for doing this analysis was, we started off with the first week. And when the patient comes up for follow-up in the 4th week, that is the start of the 4th week, we would be able to generate the results, and the counseling would be done in the first follow-up visit. So the next important thing, especially in our parts of the country, especially in the developing world, is the cost of genetic analysis. We brought down the cost of genetic analysis to an equivalent of $250 US. And we had about a sensitivity of 95% for somatic mutations and 90% for germline mutations in the bilateral RB patient's blood. So the major outcomes were we could identify the familial RB, could make out the twin discordance. We did an analysis of de novo germline mutations as somatic mutations. Could also do a prenatal identification. So I'll go through some of the case scenarios. Here it was a proband who presented to us at 4 months, and he had a bilateral RB, and we realized that the mother had enucleated earlier on in her life. And we did not know the reason, but we assumed it would be a retinoblastoma. So in the subsequent follow-up, when the mother turned out to be pregnant, we decided to go ahead and do a genetic analysis and found out that the mother and the first child had a similar mutation. And then we asked the mother to bring the child as soon as the child was born. So the younger sibling was brought to us when she was 12 days old, and she was found to have group B retinoblastoma in both eyes, which was easy for us to treat. Of course, as Santosh was mentioning earlier, in our part, it's very difficult to do an intra-arterial chemotherapy. So we went ahead and did a intravenous chemotherapy and salvaged not only the eyes, but also the vision of the younger sibling. The second scenario was the proband presented to us at 36 months of age. There was no family history of retinoblastoma. It was a unilateral group E retinoblastoma, but then we found a germline mutation in the blood of the patient, which means it is a heritable entity. So the next one was a proband was 26 months old with a group E retinoblastoma. Germline mutation was identified and the child was closely monitored, and the patient turned bilateral during the treatment period. And analysis of parents showed the father as an unaffected carrier. So there was a prediction of a higher risk for the next sibling. Now, this was a 3-year-old male with a group E retinoblastoma with a retinal detachment with no family history of retinoblastoma. A primary enucleation was done and a homozygous methylation only in the proband's tumor was identified. Now, in the older patients, now after having listened to all these patients, the younger ones who had been enucleated about 20 years ago started reporting to us, asking us for knowing whether there is a risk of retinoblastoma in the offspring. So this was a unilateral patient whose eye was enucleated for retinoblastoma. There's no family history of retinoblastoma, and no mutation was found in the patient's blood. And so therefore we predicted a less than 1% chance of getting RB in her offspring. She got married and she also delivered a child who was brought to us and did not have any retinoblastoma. Risk of secondary tumors. There are children who come to us after 20 years wanting to know whether there is any other chance of having a secondary tumor. Again, this child was enucleated at the age of 2, and she wanted to know whether there was a chance of secondary tumor. But since the blood did not show any mutation, we said that there was not going to be a risk of secondary tumor. So this is a 20-year-old female unilateral retinoblastoma enucleated at 1 year of age, and genetic testing unfortunately showed a germline mutation, which is heritable. So this was a 24-year-old female with a unilateral retinoblastoma enucleated at 2 years of age. No family history, heritable nonsense mutation was identified, and this was counseled to the patient. In another scenario, there was a familial RB. This was a very interesting family with 4 affected members. The proband's wife was 2 months pregnant. So the proband and the mother had heterozygous deletion of exons 3 to 13. And then the prenatal testing was done for the proband's baby, and the same deletion was found in the fetal DNA, unfortunately. So then after having done all this, we started to go ahead and do the identifying the copy number gain and loss, which was discussed by Dr. Chantada. And we are now looking for copy number gain and loss in cancer genes through the targeted NGS. Epigenetic alterations, apart from the genetic changes, also plays a major role in progression. So whole genome level epigenetic changes are being studied by the methyl arrays and the microRNA profiling. Now, we also did a little bit on understanding the mechanism of chemoresistance. In spite of various treatment modalities, still about 30% of the patients do not respond to the current therapy, and we are now in the process of elucidating the possible mechanism of therapeutic resistance using various cellular assays. And what we found out was there was an increased expression of stem cell markers in non-responsive eyes, which provides an evidence of cancer stem cells and therapeutic resistance. And there is another interesting finding that we found out was there were somatic mutations were found in patients whose parents had an age difference of less than 10 years. And there was de novo germline mutations in RB patients whose parents had more than 10 years of difference. Here, the social setup is such that the age difference is usually 10 years or more until about 10, 15 years ago. But now people have started realizing, and the age difference has significantly come down. But this was a finding that we found out, which was quite significant. So to summarize, identification of the RB1 germline status of a patient allows differentiation between sporadic and heritable retinoblastoma. Genetic testing and genetic counseling is crucial for assessing short-term risk of additional tumors in the same eye, other eye, and the prognosis, and long-term risk of non-ocular malignant tumors as well. So it is important that every patient with retinoblastoma requires to go through a genetic analysis. Thank you very much for the opportunity.
Thank you, Dr. Kim, Dr. Usha Kim, ma'am. Since Dr. Vikash Ketan could not be here, we would like to go ahead with the last two questions of the quiz.
Sure, thank you.
The question number 24, prenatal diagnosis of retinoblastoma mutation can be done at which stage? A, non-invasive prenatal diagnosis at 8 weeks. B, chorionic villi sampling at 11 weeks. C, amniocentesis at 16 weeks. Or D, all of the above. And last question 25, relapse or recurrence of tumor is defined as regrowth or new growth occurring after a minimum of dash months, progression-free and treatment-free follow-up at monthly examination. A, 1 month, B, 2 months, C, 3 months, or D, 6 months. Okay, we're done with the quiz, and we would like to go ahead with the faculty discussion. So I would like to invite Dr. Shantada to take the first discussion.
Okay, thank you very much. I think we had an extensive discussion already for the extraocular disease. I think I would like to hear perhaps some comments from Santosh. He has a greatest experience in orbital disease. I'd like to hear your thoughts, Santosh, if you don't mind.
I think your idea is wonderful, intraarterial chemotherapy, especially because it gives a very high dose to the optic nerve and the orbit that can take care of the local disease, while intravenous chemotherapy would take care of micrometastasis. Combined radiation following surgery and adjuvant therapy would probably enhance success further than what we have already. So I suppose it's a great idea. And we could possibly try that we have, unlike in the West, we have patients who on MRI would have 4 or 5 millimeter optic nerve involvement, but they still have possibility of eye salvage because it's not an advanced disease. There's no neovascularization of the iris, etc. But on MRI with contrast, we find that there is about 3, 4, 5 millimeter optic nerve involvement where intraarterial chemotherapy may work better than IVC.
Yeah, I totally agree. Yeah, that's very, very important. Carol, any thoughts? You've been quiet for the past few presentations.
Yeah, so I've really been listening and taking notes. Yeah, I mean, I just sent an email to Ann Leahy, our pediatric oncologist, with your ideas. Did you only measure the topotecan dose then in the optic nerve? Did you do a similar study where you measured melphalan dose in the optic nerve?
Oh, we haven't, but that was because for technical reasons, we have very, very well done the analysis from topotecan. So we are very reliable. Our measurements were very reliable. So that's why we didn't do it, but we certainly can. And also with carboplatin, but the way you measure topotecan is very, very exact. So that's why we did it. Yeah.
You've done so many studies measuring the topotecan in the vitreous retina and optic nerve. So this is really a great contribution. It would be interesting for those of us who see retinoblastoma with optic nerve invasion to have your protocol, apply it, and just see in collaboration how we all do, because stage 4B is really, I mean, even in Philadelphia, we just shake our head and we say there's nothing much we can do, but maybe there is a little bit of hope.
Yeah, thank you. Yeah, these are what these very few pilot cases would encourage us to do. So I think that is what we are going to start working from South America.
Let me just share a case with you. We had an interesting case with a very large retinoblastoma that we treated with intraarterial chemotherapy, and the patient did beautifully. The tumor resolved, but the scar was sitting right on the optic nerve, right on the disc. So we couldn't see the disc. So we imaged the patient after IAC, and the intraocular disease was completely clean, but the kid developed disease in the optic nerve. And that was only detected on repetitive imaging. So we had to enucleate, and this child is undergoing treatment right now. And that's why I sent the email to Ann Leahy. Maybe we should consider this approach to his care. That's the first case we've seen that's the first case that we have seen with optic nerve recurrence after IAC.
Yeah, that was also our concern in that experimental study. That's why we studied 3 parts of the optic nerve to see perhaps that the intraarterial chemotherapy would give another homogeneous coverage. But we found that the chemotherapy levels were the same in every level. But we had one case like yours, and I know of another case right now in Europe that we have seen also a recurrence, an orbital recurrence in the optic nerve, which we, at least me, I haven't seen before. I don't know, David, did you see any case like that?
We have one case treated extensively for 6 months with multi-agent systemic chemotherapy, then regrew, treated then with intraarterial chemotherapy, and looked good for a few months, and then came back with a regrowth truly over the optic nerve. Most of the time it's just adjacent the optic nerve, but literally over the optic nerve. So we knew it was in the optic nerve. The MR showed extension into the optic nerve. The systemic workup showed nothing. We treated him with intraarterial chemotherapy only, and he's now more than a year out, still has the eye. The actual stuff in the optic nerve went away after 1 intraarterial. We did a total of 3.
And the dose that you used was melphalan?
We bumped it up. Yeah, exactly right. We bumped up the dose primarily of melphalan. We all know that if you get above about 0.48 milligrams per kilo, you start running into hematological consequences. But on the other hand, if you're talking about something that could save the eye, some of the patients will tolerate higher than that without getting into real clinical problems. So we go up by about 30% in the dose, and sometimes we've gone up and doubled the dose and actually gotten away with it.
What's the highest dose you've given of melphalan intraarterial?
Well, the highest dose has
Our
been
highest dose is
like
7.5 milligrams.
Yeah, in general, that's exactly our case also, but we've gone as high as 9 and we've gone as high as 12, but this is primarily, as you pointed out, in the older children who are bigger and a little bit bigger eyes and a little more vigorous blood flow.
So Guillermo, what's the dose of topotecan you would recommend for optic nerve invasion?
We could, I know that the French group went up to 4 milligrams. So we can go up to 4 milligrams for that. We have only used carboplatin because we know about, it was published. So we know that 200 milligrams was okay, not toxic to the CNS. That's why we just, we were quite conservative for well, we were a little bit both, but we wanted to use the treatment that was already published because we were quite afraid the first time we gave 200 milligrams of carboplatin intraarterially. I have to confess that.
Let me add, if I can, a little bit about the optic nerve level of invasion. Yes, the patient that I presented to you had a clear optic nerve head lamina cribrosa and a little bit beyond the lamina cribrosa in Plony. But the recurrence was in the postlaminar optic nerve, where you don't have any of the other near the short ciliary vessels. So I think, and this case was an intraarterial chemotherapy relapse. Everything was clear inside, but only postlaminar, where there's no more of the choroidal vessel in there. So I think your intraarterial chemotherapy affecting the optic nerve may be good for the anterior portion, but the posterior portion, what we found in this patient that recur in the CNS is meningeal involvement down. So it's already in the meninges. And so I think that part is very important because it's not covered by much of the circulation, as is the anterior portion. So, it's already in the meninges and it's already there where it didn't reach. I think that's one of the explanations.
Yeah, that's a very important point, Patty. Thank you. I also had a question for you, Patty. And one thing that we didn't mention was the immunotherapy approach, also for metastatic retinoblastoma, or for retinoblastoma in general. Carol mentioned our study with the virus, but we have treated 2 patients, for example, in Barcelona with anti-GD2 antibodies, like are used in neuroblastoma. Have you done any studies on the immune infiltration in this extraocular cases or in retinoblastoma in general, because there is very few written about that?
Yes, we did it when we wrote the paper on toxicity in gene therapy. When we did our first paper showing that the best results were the ones that had a lot of inflammation, macrophages and lymphocytes and stuff. And then we did the immune response because people were very worried about systemic immune response in this intraocular gene therapies. Remember that we were the first to put some gene therapy in the eye. So everyone was looking at that. And so we look at that and we did not find anything outside of the eye. Everything was inside, and it had a specific response of T cells, but with also with some plasma cells in there. So you have your B cell response in the eye, in the treated ones, the prime ones. And it is different than the normal tumors, because I had some controls, and the normal tumors without any gene therapy did not have that response. Yeah.
Thank you.
Guillermo, we had one case, I think you know it, of CNS disease that we treated with 3F8 that had an unequivocal response, that is 3F8 directly into the CSF, had an unequivocal response. The patient progressed and died. So maybe the frequency, the dose, who knows what, but there was definitely a response.
Yeah, I think that's also a way to go. There is another drug that it's been pioneered at Memorial, is omburtamab, which also targets, it's a radioimmunotherapy target of these immune response modifiers that I think can provide additional expectations for success. So I didn't give up to try to cure CNS retinoblastoma. I think we need to think out of the box, and try to come up with some innovative treatments. I think we cannot be happy with 10% survival rate. We have to keep on struggling.
Can I have a question to the panelists and faculty here? It's regarding pinealoblastoma. So what is the prognosis that, of course, there are very few cases which is presenting as pinealoblastoma, but does chemotherapy help? Does improve the survival? Is there anything new that has come up to improve the survival in these children?
Yeah, let me just tell you that the curve I showed, or the 4B patients, includes pinealoblastoma. Okay. So they are also having a very, very bad outcome when they are disseminated.
Yeah.
So I don't know if anyone would like to comment on that.
100% of the patients who were picked up on screening with MRI, we have 100% have died. So the only ones that have survived, and we published them, are the ones that were picked up with signs or symptoms. That is more than discouraging. So the whole idea of screening with MRIs, which we've all done, we no longer do it after the age of 3. There was just a paper on that suggesting you don't have to do it till after the age of 4. But we don't do it after 3, and we have lots of false positives. And when you get down to the bottom, it doesn't matter because the ones you pick up on scanning, in our case, have all died, all 100%.
Dr. Carol?
Yeah, so we have some survivors. I'm not a pediatric oncologist, but I know Ann Leahy uses high-dose chemotherapy, stem cell rescue, and there have been a few survivors. And we still do screening just because medical legally, I think it's really important to oversee the brain and this related tumor. And we still screen, even though the paper, I think by Cavella said you could stop screening at 3 years, we still go to 5 years of age.
And Dr. Carol, does it depend upon the size of the pinealoblastoma in the initial presentation, relating to the prognosis?
I'm not sure if it relates to the size. It possibly relates to the dissemination, but I think Dr. Chantada or Dr. Reddy could better speak to that. If it's not disseminated, you may have a greater chance, I would think.
Yeah, I agree. And I think these are probably the few ones that survived in the COG study. And I think that's exactly the point. When they are disseminated, I think and also there is a biology difference. What we have a very few cases studied, but you don't see what you see in unilateral cases and CNS dissemination. The genomic pattern is completely different in trilateral disease. These are more, these cells are more differentiated. They have less genomic alterations. And with that, they are less sensitive to chemotherapy because these cells that are very aggressive, but they are still very sensitive to chemotherapy. But trilateral disease is really, really difficult to treat, at least in our experience. And also we need innovative treatment for them, I think.
You know, we published a case this year of a child who was detected in utero. There was an elevated alpha fetoprotein, led to ultrasound, led to recognition that there was a mass in a unborn child's brain that occupied about 30% of the brain. So that child hadn't been diagnosed, hadn't been born. Ultimately, when born, had trilateral retinoblastoma. Child miraculously is still alive now 7 years later. But it made me think that these are probably all present prior to birth, just as I believe all the retinoblastomas we treat in genetic cases are present prior to birth. Don't think, we certainly see them pop up after treatment. We know that very well, but that's what we see. I believe, and I won't go into all the evidence, that they're all present prior to birth. In fact, they're prior to even the last month of pregnancy. How we prove that is another half-hour talk.
Absolutely. Any other comments from the panel? I think we covered quite a lot of these controversies in extraocular disease, I think. Oh, David, I just have a question for you. That the case you mentioned, the one with the optic nerve metastasis, did you have the liquid biopsy results? Or are they secret?
I'm only supposed to talk about things that are published. However, you pioneered looking at the CSF for things other than cells, because we know how disappointing that is. By the way, if you do a spinal tap and let the cells drop into the little containers without fluid, they will stick to the side of the tube. And when you spin it down, you're just spinning down CSF. You'll never get any cells. So you want to drop it in, and I know that we did more than 1,000 in a row. I did say 1,000. So what you want to do is drop it into the fixative directly and have fixative in the tube. Otherwise, you'll never have positive. That didn't answer your question, but because the CSF is not as quiet as we were all taught. You know, there's quite a few things that are in the CSF, but compared to blood, it's quiet. So we can take really tiny amounts of CSF and do impact analysis, which gives us an analysis of about 500 different cancer genes. Very, very elegantly, it's a signal to noise issue. And in the CSF, you can find some interesting things.
Okay, so you have to see the next chapter.
I can't write as fast as Carol.
You know, but David, I remember back in the early 2000s, mid 2000s, you know, like 2005, 2006, you and I were at Wills Eye Hospital. You came up to me. It was a fluorescein meeting, the Atlantic Coast Retina Conference. And you came up to me and you said, I have this new therapy I'm working on. It's called intraarterial chemotherapy. It really works. And then I whispered to you, I have this new therapy called intravitreal chemotherapy. It's before Mounier ever wrote about it, because Kaneko visited us. And I said, it's amazing how this intravitreal chemotherapy works. And we were sharing those ideas back then. Here we are 15 years later. How much progress has been made?
That's so true.
Crazy.
Absolutely.
And, you know, we should give credit to Patty. Patty, can we give you a little credit, a pat on the back? We are all extremely grateful to Francis Mounier for whatever word you want to use, clarifying, teaching us, getting us all back into
courage
the world.
to do it and write it.
Yeah, and he gets it. But there's a big but. And the but is that the drug came from Kaneko, who was injecting intravitreally. People criticized him greatly for 20 years. And the techniques for safety, Patty thought of probably before you were born, Carol. I mean, it goes back a long time now.
No, the first report, but Patty, the first report on how unsafe melphalan was came from me. Fariba Gassemi and we published how, you know, you're really limited in the amount you can inject into the eye, because she was handed 50 micrograms. Okay, we're supposed to inject 20 to 30 micrograms, and in Iran she was mistakenly handed 50 micrograms, and she injected that in 3 eyes, and all 3 eyes went into ptysis bulbi. And in retrospect, she realized it, and we published that because it was. We didn't want anyone else to make the same error.
So, you know, in China, when they do a vitrectomy, which I'd be delighted not to discuss, at the end of the procedure, the surgical procedure, they put in 200 micrograms of melphalan. I didn't say 200. So it's a little hard to know needless to say, the eyes, some of them get to people like Patty. But it's possible you could cure things with a dose that high, not keep an eye, of course.
Dr. Abramson, I think they do an infusion of 200 microgram or 100 microgram. It's not like, injection directly. It is.
So it's going in with fluid and coming out again?
Correct.
Yeah.
It's an infusion.
The wash.
It's sort of like a quick Windex of the retina.
It's in the infusion fluid. It stays in the infusion fluid for its half-life, which is 45 minutes or maybe more. The infusion fluid is placed with melphalan after priming the machine and all of that, just before the case starts. Yes.
That's right.
Yeah, so it's not like a direct injection of 100 microgram.
So if you have no more questions, can we close this? It's been 4 hours of wonderful intellectual exchange. I thank all the faculty for their time and great inputs. Thank you all. Thank AIOS for
It was great.
Yeah.
Thank you so much.
Great, thank you.
Announce the quiz winners. Namrata, do you want to say a final closure remark?
I would just like to thank all of you for making it happen. Almost a 4-hour webinar, and we know that when Santosh organizes, it has to be 3 hour plus. But then so many things I'm sure have come out of it, and it was a great treat. And you all know that we've had a huge viewership for this program, 1,000 plus. I think it must have crossed 1,500 now across all platforms, and this will keep populating as the time goes on. So thank you, Dr. Santosh. Thank you, Dr. Usha Kim, for agreeing so immediately to do this with the OPAI, as well as Dr. Mukesh Sharma. And it was just one phone call, and Dr. Usha Kim agreed immediately that we'll do this thing in the Retinoblastoma Awareness Week. And thank you so much. We would like to thank our audiovisual team at the back end, Mr. Sunil and Mr. Kripal, for helping to organizing with this, and all of you who are in the COVID times in different time formats globally. And thank you for your presence, for your time, and for your contributions. Thank you, Santosh.
Right. The quiz winners are Samiksha Tadepalli from PGI Chandigarh, Harika Regani, who just finished a fellowship with me, and Vikas Khetan. Congratulations. Yeah, yours is a prize for them.
What's the prize, Santosh?
Yeah, yours will give it to Amrita as boss. She will probably organize.
Great, congratulations.
Amazon gift vouchers, and we'll be sending them soon.
Yeah, Amazon gift vouchers. Thank you, Namrata, for that.
You call me Santosh, so okay. Thank you so much.
Good night, everyone. Stay safe. Stay safe.
Thank you. Bye-bye.
Bye.
Bye.